Hi, Deeptesh.
Yes, Fiona.
Yeah, it's 7:30. So can we start to that meeting?
Yes, please, you start.
Okay. So good evening, every doctors and professors. I'm Fiona from Mary. So at first, I really welcome all of you join this dialogue. So at first, I would like introduce our customers and were kind of like good friends from China. Uh, Professor Zhiyong Peng, director of ICU Zhongnan Hospital, Wuhan University. He has a lot of experience about the COVID-19. So welcome, Professor Peng.
Hi, hello, good afternoon.
Hi. So then I will let my colleague Deeptesh introduce all the doctors, professors from India. So after that, then we can start that meeting. Okay, Deeptesh?
Thanks, Fiona. So, hello everyone. Good evening. I hope you can hear me loud and clear. I'm
Yeah.
Diptesh Malik, Marketing Manager for Mindray India. I'll be the moderator for today's webinar. So, as COVID-19 is rapidly evolving and spreading globally, we think it is Mindray's honor and responsibility as well to establish a platform for all the international communication to happen among clinical experts from different countries to better fight against COVID-19. Today, it is our great honor to have two panelists sharing their keynote speeches with us. Firstly, Dr. Zhiyong Peng, our guest speaker from China. As introduced by my colleague Fiona, he is a professor of critical care medicine and anesthesia, director of ICU of Zhongnan University at Wuhan University, Zhongnan Hospital at Wuhan University. Dr. Pong has been fighting COVID-19, handling this extraordinarily challenging situation in the past 4 months, right at the epicenter of the pandemic, that's China. With great efforts from the frontline clinicians, including Dr. Pong, China has now seen a large decrease of new cases now. Welcome, Dr. Pong.
Hi, hello,
Hello.
good afternoon.
So Dr. Pong is electing chairman of the critical medicine branch of Hubei Medical Association. He's a member of Society of Critical Care Medicine of USA since 2007. He's a member of American Thoracic Society since 2006. He's a member of European Society of Anesthesiologists since 2002. He is VP of Hubei Province, Chinese Society of Critical Care Medicine. He's the General Secretary for Critical Care of Chinese Society of Anesthesiology as well. He is the board of editorial member for Journal of Critical Care USA. His areas of special interest include critical care and anesthesiology. He has more than 30 years of experience in healthcare now. He has written abundantly around publications of more than 100. He has achieved an award, which is Star Research Achievement Award, awarded to him by Society of Critical Care Medicine under US mentorship. He also received an annual award from Society of Critical Care Medicine USA in 2009. He has received the prestigious Harry M. Vars Research Award by Aspen USA. And he has also been awarded the National Excellent Science Books First Prize Award by China, 1996. Welcome, Professor Bong. Also,
Hi.
along with our friend from China, we have very esteemed Dr. Muralidhar Joshi with us. I take this opportunity and privilege to introduce Dr. Muralidhar Joshi, who is the National President of Indian Society of Anesthesiologists in India, which is a society of strong 37,000 plus anesthesiologists as members in it. Also, he is the governing council member of World Federation of Societies of Anesthesiologists for the past 4 years now ongoing. During this COVID time, especially in India, Dr. Joshi is actively taking part in formulating the SOPs, work guidelines, protocols, and various directives for World Federation and ISA. Welcome, Dr. Muralidhar Joshi.
Thank you. Thank you.
Yeah. So, Dr. Muralidhar Joshi is the head of Department of Anesthesia and Pain Medicine. Also, he's the director of Pain Management Center at Virinchi Hospitals, Hyderabad, which is in India. As I said, he's the national president of Indian Society of Anesthesiologists in India. He's the GC member of WFSA. He's a member of WFSA Pain Relief Committee for the past 4 years as well. He is the ex-board member of Asian and Australasian regional section of WFSA. He is an ex-sub-editor of Pain section ATOTW. In 2015, he was a part of WFSA in this regard. He is the honorary secretary of Indian Society for Study of Pain, ISSP. He is the honorary treasurer of ISA. He is the reviewer for various national and international journals as well. Dr. Muralidhar Joshi's areas of special interest include pain education and interventional pain management. He has total experience of over 25 years in healthcare now, glorious 25 years. He is the author of 6 books, many articles, some books which include fiction as well. He has been instrumental for the first Android application development on interventional pain management. He is the first to start fellowship in pain management in India. He is the first to author a textbook of pain management in India. He is the first to start e-learning in pain management in India. His one of the highest awards is the Academic Excellence in 2010 by the prestigious body of ISA India. Welcome you, sir.
Thank you very much. Thank you.
So over to Dr. Muralidhar Joshi now for his presentation of today.
Hi, Peng.
Yeah, Dr. Pong is on mute, sir. So you can
no
continue.
problem.
Yeah.
Hi. Yeah. Hello. Good afternoon.
Good afternoon. Hi, Dr. Peng. Nice to hear from you.
Okay. Me too.
Deepta, is okay? Fine? Comfortable?
Absolutely, sir. We can
Yeah.
go live now.
Yeah. Good evening, everyone. And I know all of us are literally sitting on ticking time bomb these days, especially about the COVID-19 pandemic. Probably the generation which is attending today's program might be this one of the first pandemic which we are seeing. It probably we don't want to see any more after this, probably. But having said that, like, somewhere we know about the history, how it started and all. Started somewhere in the last week of December, first reported at China, to Wuhan province. In fact, we have one of our faculty member, Dr. Peng from Wuhan, so he should be able to share his own clinical experience. The question is, it has started so there, went to different countries and across different continents and all, showed its manifestation affecting some country pretty seriously initially and subsequently slowing down. Some countries affecting late and like hitting it very hard, those countries. And every country is going through its own correction modalities and all those things. But in the process, there has been a huge, I should say, social and life loss and also economic loss, which is incomprehensible. All our mankind has not seen. Probably I would like to say the only one group of probably the things on this earth, probably they are enjoying this particular period seems to be the nature. The nature and its probably the birds and probably the animals and probably in the forest and whatever you say about sea and all, because they are all lively and all because there is no human interference. But having said that, we have done our own best thing, whatever was possible for the globe and all those things, pollution and wake up call for all of us, falling water, we might have damage the ecosystem in the nature, because after the lockdown, a lot of things are improved. That's on the one side of the story, but other side of the story, the lockdown cannot be permanent. It was only to make sure that the countries develop enough infrastructure or probably resources so that subsequently they can take up probably the reconstructive work of the healthcare system and all, and probably take care of people, so that the impact of the pandemic can be reduced. Now many countries are coming out of the pandemic slowly, and as they're coming pandemic lockdown, slowly the numbers are increasing. So now nobody knows how long it will go on, what will go on, and especially for the 400 probably today will be focused predominantly on my colleagues from the Department of Anesthesia across the globe. I just wanted to share my thought. How will be our clinical practice following the COVID-19 pandemic? Will it be same or will it be different? And before we discuss about all these things, we need to have a little bit about the historical perspectives. So in this context, probably today's discussion seems to be quite interesting, and hopefully it will be productive, and probably we can learn from each other much more than what probably we can learn alone. I have a disclaimer here that no conflict of interest as far as the today's presentation, I think of that concern. Today, I'll be discussing with you about the epidemiological factors about the pandemics and all those things, how each pandemic has behaved over so many years, or over so many centuries. It's very important. Unless you know about the historical perspective of the problem, what you're handling, you will not be able to get at the grassroots level. Then we'll speak about the COVID-19, that's a current the issue, that's a pandemic which is going on, how to come out of it and how long this can last, and what are the solutions, how do we go from here. And most important is what is our current clinical practice, what we were doing before the COVID-19 hit us. And then we look at the challenges it might bring it along with it, because we need to modify our way of handling things. It may not be the same what it was earlier. And even to handle those challenges and all those things, we require some resources. We already have some resources and all those things. Here, probably we'll have the SWOT analysis. That is nothing but about what are the strengths, what are weaknesses, and what are the opportunities, and what are the threats. Of course, subsequently, we need to speak about the future. Are you going to continue like this, and how long will you go to that? If any more epidemic comes, should we prepare ourselves? The last but not least, let's not forget, these days we are hearing, we will ask maybe in a couple of weeks, and also the second wave, especially we are hearing from China and then South Korea. In this context, today this is very important. Like, it's not about the current pandemic what we have to plan. In case we are going to hit by the second wave also, we should be ready. We should take care of not only our own patients and probably the nation and all those things, but most important is you'll have to take care of your family, which is the primary importance, because without them, we are nothing. It's important to know about the previous pandemics, what all have hit the globe in so many years and all. I think now the bubonic plague happens to be having the highest number of episodes, major pandemics across the globe over the last 2000 years. And the major things which probably current the human civilization can remember is one happened sometime around 6th century, and the second one probably around the medieval period. It was about 14th century. Then we had in the 19th century somewhere, maybe around 1855 onwards and all. The 14th century was somewhere in the during medieval period, and 19th century again happened to be happens to start in China and all those things. But question here is, nobody knows how it disappeared, sporadic cases, because if you go back to the historical perspective, how this pandemic ended, you can just listen to that one. There were episodes where there were I should say the people had the lymph glands engulfed under the groin, or for that matter under the axilla and all those things. People just collapsed. Just we keep hearing, but subsequently there was little bit we have information about 1855 and onwards and all, because by then it was realized that rats were one of the major culprits for this kind of pandemic, and then they realized that subsequently it's not the black rats which are responsible; it was the brown rats. And that's once they were eliminated, most of things got eliminated. But even to this stage, it has not made a complete exit from the face of the earth. The plague keeps on happening in sporadic foci here and there, sometimes in US, sometimes some other part of the world and all. It has been happening, but definitely it's under control. It has not achieved the magnitude achieved at earlier point of time. So let's see. I hope it keeps a low profile as long as we can remember. The next major pandemic, which we can never forget, is the smallpox. It was there for almost 3,000 years. Almost every civilization on this earth has recorded the episodes of smallpox at various times and all those things. But there also we took quite some time for us to understand what was happening and all. We thought about maybe black spirit as that there and all. finally somewhere maybe in the late part of 19th century realized it was come from the variola minor, that virus. And because there are no animal host, I repeat, because there are no animal host, and the infection was obvious on the face of the person. So because the quarantine was very easy, it was not like current flu pandemic, what you have where you cannot make it. There could be somebody who's asymptomatic carrier. That kind of thing was very less with smallpox, and almost we lost probably, at least from Indian point of view, we lost almost close to 2 crore people for the same smallpox over years. The quarantine was easy, and of course we had the vaccine then that which was for the lifetime cure, and that's how we could escape from the smallpox pandemic. Then we had the flu pandemic of 1980. That is at the end of the First World War. It started, and all people didn't never realize that it almost killed 50 to 100 million people, and over 2 to 3 years, and people didn't know what was happening. Like especially the young sailors, the young soldiers, just coming and just dead dropping in the hospital or where the war was happening, and all. Nobody knew what was happening. They thought it was just happening like that. But subsequently, luckily for the mankind, it faded as a benign flu over next 2 to 3 years, and it disappeared. Now also it comes now and while, it comes like a probably a benign common cold or maybe something a little bit more than that, and then disappears. Then we had our own local endemic thing, which threatened to become pandemic, but which did not achieve that kind of capacity. One was the Hong Kong flu of 1960s, and then we had the SARS somewhere in 2003. Then we had the Ebola, the endemic city. We thought it might become pandemic. Luckily, it got contained and all those things. So if you just know about the history of the pandemic, the biggest problem is, as I told earlier, this kind of pandemic, none of the current living like the human beings have faced the pandemic so many years and all those things. We are seeing, but it actually got quieted. But this is something different and all those things. And in this context, COVID-19 is slightly different. Yeah.
Sorry for the interruption. Please
Yeah.
put it on full screen, sir. Some doctors are requesting us.
Okay.
Yeah.
1 second.
Sure.
Is it better?
Yeah, now it's okay.
It's better?
Yes.
Sorry for
Please
the
continue.
inconvenience. Sorry for the inconvenience.
Okay, sir. Please
Or do
continue.
they want to hear the previous one? Are they okay with that one?
I think you can continue.
Yeah,
You can continue. Yeah.
So the current pandemic, what we have the COVID-19, like we heard about the history, like historical aspect of the what happened with the bubonic plague and what happened with the smallpox, and subsequently what happened with the SARS, and then what happened with the Ebola, then Hong Kong flu and the influenza of 1918 and all. Now the current generation is facing the COVID-19 probably, which none of us we are mentally prepared. Anything like it just started like the somewhere reported first time December 2019. And within no time, in just about 4 months of time now, this is statistics as of today, it's 13th of May 2020. As per today's statistics, almost about, as you can see, 4.3 million people are affected, and 1.6 million people are recovered, and 2,93,000 people have lost their life. And we don't see an end to this one. We don't see an end. And it's just going on. Almost all continents are affected. Probably I can say about the Antarctica is one thing which is not affected. I'm not sure about the Arctic and all. But yes, some of the countries which are not affected, it's very important, like handful of countries, especially in the Pacific Ocean, they are not affected much about this. They're not at all seems to affect, as per my information was what I was keeping track of the pandemic across the globe. Somehow they escaped under, we want them to be away from all these things, because who's affected, let's face it. So as I can see, the whole world is stuck. It's locked down. We're stuck. We don't know how to go from here. Should we start opening it, or should we stop at this stage? Lockdown cannot be permanent, I told you. If you lock down, probably instead of dying with a pandemic, you might die with hunger. So in this kind of dilemma, when we might have to open up, I should say what are the lockdown we have and all, it's the biggest difficulty is there is no specific treatment. But if you're asking about the previous pandemic, there are no specific treatment. When we had the first few epidemics, you take it for smallpox, you take it as the influenza or 1918, or for the matter plague and all, we never had any kind of, I should say, the specific treatment. So the mankind had to go through it. As I told, social and economic damage is unimaginable. We are now looking at restarting the economy, even though we know very well we have not addressed the problem completely. So there are going to be challenges. And when we are thinking that, okay, maybe we are ready to the challenges by going through lockdown, where we slowed down the pandemic to a certain extent, where it's become much more manageable because we're able to develop the resources and all those things, we set and all those things. Now we hear from China and South Korea about a second wave. That means we have to be ready for that also. That means it's not an easy game that it came and it left. No, it's going to stay with us, and probably we'll have to learn to live with it till we find an answer. And the commonest thing is, which people keep on asking is, how will this pandemic end? If somebody knows the answer for this particular thing, then probably I would like to say probably they'll be the greatest person on this earth. I would like to at this point of time. No, nobody knows about it. We really don't know, because the takeoff was from the virus, right? Whatever it wanted to do, whichever it wanted to, and it is maintaining its own ecosystem by whatever mutation, whatever needs to be done, and the landing will be by the virus. And how it is going to do? Yes, as a passenger in the flight, if you have probably develop a mechanism or probably a vaccine or medication where you can slow down the aircraft in which you are in, and you can make a safe landing, nothing like it. Though attempts are being made, but we really don't know how it is going to come in what a form, and all those things. It's going to come as a at the end of the day, we are going to see that kind of situation also. We are not sure. Let us see how it might end. Possibilities. I am not saying that it is the possible. We can only deduce from the previous pandemics what it is there. The virus what we are handling right now is happens to be CRS-CoV-2. When will COVID-19 pandemic end? It's $1 billion question. None of us can answer. Most important, will it be safe landing or messy affair? Is it something like no? Probably by the end of the year, we are going to have the required medication, or it's going to be a crash landing, that we are going to lose more lives, and it's going to be a messy affair. One way of best and safest way of probably the landing is incidence of infection, death rate plummeting its number, and finally it needs to be like innocuous or like an insignificant, almost negligible kind of thing, and probably we might have a safe landing. The other way, which has happened with many pandemics, especially it happened with the plague and all those things in those days, Italy and all those things, and they felt that anyway they are going to do anyway, so they kept on enjoying their life, having all the nightlife, whatever drinks they wanted to have, whatever they wanted to enjoy. They thought this is the end of the world, and they wanted so. So once the fear about the pandemic disappears, we are seeing some part of it here and there. People are protesting, no more lockdown. We just want to come on the street. You can't just keep us in the house for this long time and all those things. We keep seeing people breaking out of whatever way they have been confined. And this is one of the biggest lockdown heard in the history of the world. And people might be tired of the panic mode. How long you have to be tender on hooks? Like I see today, like 10 cases in my neighborhood. And probably the previous state there are about 5 cases, and my neighborhood has 1 case, and probably the country suddenly had about 10,000 cases. This panic mode, it puts pressure on the mankind. At the end of the man, we should understand the human reaction for this thing, and probably he'll make an adjustment. Let me learn to live with the disease. Let it happen whatever has to happen. The question here is, how do the challenge we can manage these things? The challenge is here, how do we manage these things till that time, till we can find a vaccine or for medication, or if we are lucky enough, the virus mutates into a benign variety and disappears from the globe, or becomes a not so great challenge, or it might just disappear like that, or maybe it will some focus here and there where we can handle. Again, we don't have an answer for this one. The very fact that we don't have an answer says that we have more than 14,000 papers over last 4 months just on COVID-19. More than 14,000 papers last 4 months. Very fact that what they're seeing, what they're observing, they're just reporting, and every paper throws a new challenge, a new idea. Initially we thought only it will spread by the respiratory thing, and subsequently somebody said viremia can be there, it might just come from the whatever the abdominal surgeries you might do. And subsequently somebody says there could be a placenta transfer of some reports, and somebody said we saw it in the urine, and somebody said we saw it in the semen. We really don't know. So many things are being reported, all those things. 4 months is too short a time to report so many things. But yes, one thing is that it's in front of us. We have to tackle it. How we are going to do it, how we are going to make it a safe journey, it's in our hands. As well, how do we go about it? In that context, let's look at the current, probably I should say the clinical practice, what we have in our hand. So this is from another point of view, I would like to say, I'm just limiting to one specialty because it's important, because if we touch the whole medical fraternity, we'll be lost because there is so many branches are there and we really don't know. Just think about your own as an anesthesiologist. What are the areas you might have to take care wherever you might be your help might require. One with the reception or waiting area, where probably you are going to have your like patients who might be like prospective customers for the surgery or for the PNC consultation or for the pain clinic. As per the work what you are doing, that's one area. Then you got consulting office where you're going to examine the patient or probably collect information, and then what are questions you want to ask, review the reports and all. Subsequently, you'll come to the operation theater for the planned procedure for the anesthetic work and all. Then you have to go to the patient to post-intensive care unit. Then if needed, maybe critical care unit, emergency room, the transportation. Last but not the least, let's not forget, at the end of the day, when you finish your work, you'll go back to your home, your family. Definitely, that's what we aim for. I mean, how do we handle all these things? Will our clinical practice change to make sure that not only you are safe, people around you are also safe, your patient is safe, and of course, the family is safe. In this context, let's see what are the different challenges that might be thrown at us, and what are the options we have, how we can go about it, how to turn around the things. Look at the challenges. As the pandemic progresses, many asymptomatic individuals may present for anesthesia. Like that's what, like the other day I was reading the report from, of course, our own country, that's India, is that almost 60% of our patients are asymptomatic. So asymptomatic, but they might be carrying infection, and maybe they might be spreading the infection to other people who are more prone or vulnerable. The incubation period, what is being said is it's 1 to 14 days. It varies from person to person, region to region. And many countries, whether it's a developed countries or developing countries, there are insufficient kits, and even some kits are there. There could be the false negative test up to 30%. That's what is being claimed. And there are, of course, I should say, doctors with comorbidity, especially in anesthesia fraternity, the senior doctors who are there. Hospital, I think probably at least many people might be having some kind of comorbidity, like maybe diabetes mellitus or hypertension, ischemic heart disease, so on and so forth. There will be a risk doing definitely airway care and intubation or extubation, whichever you are going to say. Transmission can definitely occur at that time. In this point of time, how do you go about it? The worst thing that can follow is anesthetists with mild undiagnosed COVID-19 infections might transmit to their patient. That's the worst thing. Imagine anesthetists with mild undiagnosed COVID-19 infection might transmit. If not anesthetists, maybe the other healthcare person working in the operating room might be undiagnosed COVID-19 infection. They might transmit to their patient. That means it's both sides, from the patients to the doctors and the healthcare person to the patient. And as per the worldwide whatever report, what we're seeing, the mortality in the healthcare professionals is much higher compared to the mortality compared to the the common civilians. So that's what we have to keep in mind. So what are the resources we have in our hand at this stage so that we can make our clinical practice more safe, not only for ourselves, for everyone around us? Safe distancing, yes, one thing we have accepted so far is because of the aerosol and all those things. Safe distancing, at least not less than a meter. That's what we keep on discussing. And hand sanitation, of course, simple to definitely adopt. Like a distancing and hand sanitation doesn't require any extra cost and all. And that is going to become way of our life. Safe distancing, hand sanitation going way of our life, and henceforth. And that's the change what we can exert within our own people and all those things, and across the globe. It's going to be there forever. Looks like that. And especially PPE, that's like personal protection equipment, whatever you would like to use, whether you talk of the masks, you talk about the coverall, you talk about the shoes, or whether you talk about the goggles, or maybe face shield, or whatever you talk about, and all those things. And then of course we have the safe donning and doffing. We has to be taught to all the healthcare personnel who are involved. The face shield goggles are going to say these are the things what we have. The mask, we have triple layer mask and N95 mask. Triple layer mask, I would like to say not to underestimate triple layer mask for simple reason. It's quite water resistant and quite useful for many areas where you may not see the active patient, just more of where you're doing surveillance kind of thing. It's quite useful. Gloves, you got nitrile and the latex varieties. Latex, the problem is about allergy and all those things. Again, nitrile variety might be a bit difficult to get it, but you can get it over the course of time. Then you're going to have the coverall on gowns, and then overall gowns, shoe covers, and of course, sometimes some areas where you've got only gowns but not the cover or head cover. One commonly observed situation across the globe happens to be that the shortage of PPE kit for all healthcare professionals has been observed across the globe, and often it is seen people who are not in healthcare industry managing the patient, they are having all the coverall compared to the people who are really handling this patient. So this is going to be most of the countries have increased the production in the personal protective equipment. It might take some time before we can really realize, we can decide about how exactly we can go about it. Definitely, every country is trying to gear up to local requirements, what is being needed. So let's look at some of the areas. What kind of category, like reception or waiting area for the patient before he goes to previous checkup, we can put them under moderate risk category. We can suggest N95 mask for definitely directly dealing with the patients, and the 3-ply mask, people who are just guiding them to reach the place and all, they can manage with 3-ply mask. The gloves are mandatory, very important, because you never know the files what they might be carrying, and for the wheelchair what they might be, you never know what contamination that might be there. The gloves very important, safe distancing, and of course the patient also feel a little bit insecure because this situation was not there 4 months back when he came for the first time for the investigational tests and all of the consultation. Suddenly the elderly person who came for policy ABG, his anxiety goes up much higher because suddenly he sees everybody, or he or she sees everybody like donned in all those things. Like it looks like more like a spacesuit kind of thing and all. She can't see the doctor, and probably the golden word what is said Hippocrates oath, that is the healing by personal touch. I repeat, healing by personal touch. When the personal touch becomes a taboo, then you know what exactly the healing definition of the probably. If we continue at this rate for next generation take Hippocratic oath, they'll never understand what is called healing by personal touch. So that's irony what I would like to say, but things might change, but fine. The vitals recording might become artificial intelligence based, because what I can see is now the thermometer might go out of circuit in major hospital because it will be more of thermal imaging what it is, and same things about the vitals monitoring with respect to your pulse rate, respiratory rate, and for that matter blood pressure and all those things, and it might be based on you might get a recording. Telemedicine is here to stay, especially for they have to come for the procedure.
Sir, can you hear me? Hello, this is Diptesh.
Some of the question at home, if they're educated enough, it depends on which kind of physical status and all. If it's possible, you will take the help of telemedicine to fill a formality and ask them at the hospital. Probably, yeah. Can you hear me?
Yeah, actually your network, sir, your network got lost actually for the past 1 minute.
Can you hear me?
Now I can hear you, sir. Hello. Dr. Joshi, can you hear me?
Hello.
Yeah.
Hello.
Hello, sir. Sir, your network.
Can you hear me?
Yeah, now I can hear you. Yes.
Yeah. Is
yeah.
Okay. Can you hear me?
No, sir. Your network is not good. I think just repeat for the past 1 minute's discussion, please. Hello, Dr. Pong. We can see you.
Yes. Hey, hello.
Yes. Dr. Joshi is just coming online. He's on mute. Sir, your voice.
Yeah. That's fine. Yeah. Is it better now?
Yes. Now, sir, you have to share the screen
Can
as well.
Continue.
Please, you have to share the screen now, sir.
Yeah, no problem. Yeah. You want me to repeat the same slide, or can I move on to next slide?
Sir, please repeat it if you can. Sir, please repeat it. We could not hear it.
I cannot a problem.
No.
Yeah, that's not a problem. That's not a big deal. People should not get bored, actually. That's what I'm trying to say.
No, sir.
Yeah, I was in the reception area and the waiting area. Am I clear, Diptesh?
Yes.
Diptesh, am I clear?
Yes, sir. Now you can continue.
Can you hear me, Dr. Deep?
Yes, I can, sir. Hello.
Yeah, you can always alert me.
No problem. Yeah. Understood.
Yeah, fine. So the area of what we take reception waiting area is a moderate risk area, and definitely we expect, especially people who are handling the patient, should be wearing the N95 mask. And of course, the 3-ply mask can be used by people who are guiding who are guiding other people to about the destination and all. gloves are mandatory distance because people might be carrying away, like the files and all the wheelchair is possible. This at least I would like to this thing should be followed at least for next 6 months, if not more than that, at least 6 months. Safe distancing, we talked about a meter distance is most important thing, but there could be insecure feeling for patients, especially the senior citizens who were carrying masks and gloves and all, because there was something called Hippocratic oath which said, healing by personal touch. The touch thing goes up from here. That's most important thing what I would like to say. He's not visible and probably he's not reaching that comfortably what he was. So that's one thing we have to mentally be ready for that one. The vitals can be AI based, that's artificial intelligence based, almost the thermal temperature checking will be taken care by probably the thermal sensors and probably the pulse, respiration, and for that matter blood pressure and all those things might be taken care by some of the AI based technologies and all the parameters what can be measured by the water monitoring system. It can change. Telemedicine is here to stay. That's very important because most of the patients who might come for the proposed surgery or something like that, and they might be looking at different thing for the consultation, follow-up consultation. They would like to have the telemedicine consultation, doctor, especially routine patients who wanted to come for the follow-up, like can I change my happiness in the hospital? So telemedicine is going to be here and it's going to stay here. And possibly if you just look at about the consultation office, again, it's a moderate risk under where the doctor might be sitting. You'll have to wear the N95 mask and gloves and probably frequent sanitation, because as the patient, probably you may not be able to see 3 to 4 patients, not more than that in a per hour, because there need to be a time for the cleaning and all those things. Of course, we should not be doing any aerosol generating procedure at this point of time. But most important is you might have to restrict the visitors and attendants, because that's one thing. Maybe maximum at one attender, but he should be again low risk kind of profile with a triple air mask. And of course, he should be following the hand hygiene. Most difficult thing, the COVID-19 testing, because worldwide biggest, if you're asking like the way you're asking for the HIV and HBsAg for viral marker testing and all, if you want to ask for the COVID-19 testing, many countries may not have the required kits. But even if you required kits also, there could be false negative also. We'll discuss it about probably as we move further from here. It's very important for us to understand how we can go from here. Operating room, most of people had their own webinars and all those things. I don't need to tell you about that one. The safety of healthcare personnel is most important. Train all the healthcare personnel about infection control policies, what is required. You need a dedicated area for donning and doffing, especially for handling the COVID-19 patients. The mock donning and doffing drill has to be done. The role of observer is very important, who has to make sure that you have done a good donning or doffing. The plan for the procedure, the regional anesthesia, and same thing communicated to everyone. The preferred choice of anesthetic work should be regional anesthesia, not the anesthesia, if possible. But where the anesthesia required, it's important to go regional anesthesia, and minimum number of people in the operating room. The most important is what you should be understanding is, we'll discuss about it when we are ready for elective surgery and all. We'll have 2 groups of people. One, whatever the RT-PCR test what we are doing, polymerase chain reaction test, people who are positive, they will go for the treatment aspect, whatever finish the quarantine, they come back for surgery later. People who are negative RT-PCR will go for surgery. But there are many countries where the tests are not, kits are not available for different reasons, because they're not having enough kits for people who are affected with pandemic itself. So it's going to be gray zone for some time. In case you have an emergency case, something like that, but you don't have kits and all, you will have to have all PPE precaution, full complement set, and you have to go for the emergency, even if you don't have the test at this particular point of time. So these are the aerosol generating procedures which might happen in the operating room, especially for if you're going to go for general anesthetic as such. Most people pre-oxygenate the patient for 5 minutes, the face mask and for circuit, what you have with the HME filter, which is the viral filter again. Check the anesthesia workstation and get full PPE for anesthesia, especially if you're having a suspect COVID patient, but you don't have a test to do it and all, or probably somebody who is symptoms are like but was test negative. And the communication, probably because once you're fully down, communication might be poor because of the sound getting filtered. You might have a phone, probably if the hospital has phone, fine. Otherwise, probably somebody will have to have the phone covered in the plastic cover and all. Need to use the standard monitoring like with respect to pulse rate, respiration, or maybe blood pressure, what you are doing regularly, venous access, and whatever the suction, what you need to do, because there could be the aspiration, something like that. Plan for rapid sequence induction, because the most experienced person should be like intubating the patient. Reason being, the more attempts you take, more amount of aerosol get generated, probably other person can get affected. You should be using the face shield as much as possible, and there are some intubation masks or probably some the sheets which are being used. You can try those things. If manual ventilation is required, please always use the small tidal volume, don't use the large tidal volume. It's best to intubate with video laryngoscope, because you can see the structure directly, but avoid the fiber bronchoscope as much as possible, because that again induces more aerosol, and whole actually theater staff gets exposed. Once you secure the airway, clamp the tube, connect the HME filter, connect the circuit, check air entry, one more HME between the expiratory limb of circuit and maybe worst station you need to connect. Institute mechanical ventilation, stabilize the patient, and then avoid the high flow nasal oxygen. If some other cases where you might do CPAP, BiPAP, all these things you're already aware. I know about that one, because by now you must have been having a good number of webinars as such. After surgery, try to extubate the patient in the operating room as much as possible, shift them to a PSU. And all area equipment should be decontaminated and disinfected according to the hospital protocols. And the bin containing the dirt equipment should be safely disposed. Thorough surface cleaning of operating room needs to be done. Doffing should be done in the designated area. Definitely take care not to touch face and hair before washing hands. Practice the hand hygiene before and after the procedure. Make it a habit. Sometimes you might be asked to transfer a known or suspected COVID-19 patient to some other areas, maybe for investigation. Transfer only for procedure studies is essential for the patient's improvement. The HEPA filter should be inserted at tracheal tube or Y-piece. Patients who are not ventilated should wear a surgical mask. One person should wear the appropriate PPE, and if could, ideal accompanying person member do not have to wear PPE, but because he'll have to handle the other local things which might be required to help him in moving that area. There are suggestions for changing COVID-19 operation theater. Some institutions, they want to go for separate theaters because the pandemic is going to last for 2 to 3 years. They want to make it a separate block, utilize it as such, so that they can limit the exposure to healthcare person. Air conditioning system, there has been discussion about whether to have the negative one or the normal pressure kind of thing, about the central suction kind of thing, because again, suction if it has to come back and all those contamination. Scavenging system, a lot of work is being done. Things people are exploring and doing research on that one. Most important, we have defined the flow of patient transfer within the hospital. The laparoscope procedures are known to have a big spread of the viral and the load in the I should say procedural room. We need to be careful about that one. Wherever possible, the recommendation currently has been to either like open procedure type of laparoscopy, but a newer paper they say you can still go for it. Most of the body fluids are contaminated. That's why they're not encouraging even the autopsy and other things. We need to be careful about the waste of disposal of waste. Very important at this stage, because that's one thing neglected again can become like an endemicity in that particular area. So to conclude, I would like to say you need to know when to start elective surgeries. That a lot depends on the local authorities when they feel the number of the patient load is coming down, and resources like whether you have enough ICU beds at your place which can take it if required, and personal protection equipment are really fully equipped and personal or safe. And we have the COVID-19 testing if required is one more thing. The priority, which kind of surgery do you want to go for? Transplant, cardiac things beforehand, rather than thinking of other things. And there are 5 perioperative phases, very clear. That is preoperative phase, that's patient appearance checkup. Then immediate preoperative, this all discussed by the ASA. Immediate perioperative phase where you might have to repeat the COVID test again if required, and data, and then subsequent intra-op, then post-op, and subsequent follow-up. The data what you obtain, you might have to share with your country. Then we have to get prepared for second wave and how it is going to come. We don't know, but our plan will not change much. And safety is important. In between, if we get some medication which can help in controlling the pandemic or probably vaccination, that might make our life much comfortable. And a lot of ifs and buts, but these are the initial thoughts I just had. I just wanted to share with all of you. And you're most welcome to give your own suggestion, thoughts. And the only way to improve ourselves is taking input from others. With these few words, I would like to stop at this stage. And thank you one and all.
Thank you, Dr.
Over to
Joshi.
you.
Yes, thank you, sir, for your opinion. And we will have an extensive discussion around it also.
Yeah.
Over to Dr. Pong now for his discussion.
Okay. Hello, everyone. Good afternoon. It's my honor to share my experience with you. I'm Dr. Peng from Wuhan, the epicenter of COVID-19. Today, my topic is what we learned from the outbreak of COVID-19. So I will briefly talk about the general features of COVID-19 and how to intubate the patients for COVID-19 and the key points of ventilation support for COVID-19. So the basic features of COVID-19. So this is the general features, so including the ages and comorbidities. So you can see most of the patients were middle-aged with some comorbidities, including the hypertension, diabetes, cardiovascular diseases. And the patients in the ICU were relatively older and with much more comorbidities compared to patients outside ICU. So this is the most common symptoms of COVID-19. So fever, fatigue, dry cough, myalgia, and dyspnea. And about 10% of the patients presented initially with abdominal symptoms and finally developed fever and dyspnea. So this is the clinical process, the timing from the first symptom to dyspnea, around 5 days, 7 days to hospital admission, and 8 days to ARDS development. So this is the lab test on the hospital admission. So the typical lab test including the lymphopenia and elevated LDH. So this is the typical chest CT, which is a ground glass opacity. So actually, the initially occurred from the lower part and the peripheral part of the lung, and gradually moved to all the lungs. This is the general features of the patient in the ICU. The Aperture score and the SOFA score actually not so high compared to the ARDS from other etiology. However, the peripheral ratio is quite low, which indicated most of the patients developed severe ARDS. And this is the organ injury. So the ARDS were the most common organ injury, and egg cardiac injury, arrhythmia, shock, also egg kin injury. So this is the ventilation support around half of the patients requiring intubation, and some of the patients switch to the ECMO. So next, I will talk about the strategies of tracheal intubation for the COVID-19. So just Dr. Josh said, this is quite important for our anesthesiologist as well as for the intensivist. So before the intubation, we need to prepare well. So we need to prepare the experienced personnel, also with good PPE training, and also we prepare for the intubation strategy. and the backup plan. So this is the PPE using for the intubation. So this is the N95 mask, and also with the eye shift goggles, and also with the hood with the PAPR or without PAPR. So during intubation, we need to prepare to prevent potential circulatory collapse and hypoxemia. So we
Dr. Pong.
Hey, hello.
Hey, so yeah, sorry for the interruption. Some people are requesting you to increase the volume, please.
Okay,
if you
okay,
can.
okay.
Yeah. Great,
Okay.
great. Thank you.
Okay. So here, so we need to prepare for the intubation. So we prepare for the prophylaxis vasopressors, also bolus of fluid to prevent potential hypotension. Of course, we using the pre-oxygenation with 100% oxygen for at least 5 minutes. And we using the calamine or midazolam for the induction. We use lochlorium. We try to avoid propofol for the induction. We using the modified rapid sequencing induction. So this is the intubation procedure. We're using the video laryngoscopy, just the Dr. Josh mentioned. And also, of course, we prepare the different device, airway device backup. So we using the ETCO2 to confirm the placement of the intubation, the tricky tubing. And so this is the reports from our study, and this is the compare one hospital to another hospital in our city in Wuhan. And you see this is for the PPE. Almost everybody using the the N95 and as well as the surgical mask and the goggles. Also the hood. So no one got infected during the procedures. And also you see the almost the patient, almost the patients. I mean, almost everybody received only one attempt for the intubation, and for the advanced events, most of them complicated with the hypoxemia, almost 60% to 80%. And some of the patients are complicated with hypotension. So, and you compare the different region. This is for if the patients using the prophylactic vasopressors in the hospital A, and the instance of the hypotension is quite low compared to the hospital without using the prophylactic vasopressors. So this is almost 1/3 of the patients developed hypotension during the procedures. And also after the intubation, you can see still some of the patients have hypoxemia and hypotension. So this is actually this is quite a risk procedures for our patients. So we need to prepare well. So this is the lessons we learned. We need to prepare for the for the vasopressors, also the bolus of the fluid to prevent the circulatory collapse. Also, we need to prepare the pre-oxygenation. I mean, at least 5 minutes to avoid the hypoxemia. Also, we minimize the probable use during the induction. So lastly, I will main focus on the key points of the ventilation support. So actually for the medications using for the virus, so this is the mechanism between the virus and the cells. And based on the mechanism, we can choose the, the monoclonal antibody, chloroquine or hydrochloroquine or lapinaven or remdesivir. So actually, from my experience, no any medications demonstrated effective for the virus. So the key points for the ventilation support, I mean, the non-protective approach is extremely important. And we prompt the patients as early as possible. We evaluate the model of the ventilator regularly and to see how the patient responds to the ventilator, to the ventilation. Also, we titrate PEEP, we titrate the tidal volume. We need to be careful about the lung recruitment maneuver. So we have the flow chart to choose the different models of the ventilations. So based on the P4 ratio, so this is the, if the P4 ratio is 200 to 300, probably we choose a high flow nasal cannulation. But I highly recommend this should be used in the ICU with the negative pressure. So we evaluate the patient response every 2 hours based on the LOX score, which is calculated from the respiratory rate and saturation and fraction of the oxygenation. So if the LOX score more than 3.8, continue. If less than 2.8, stop. And if the P4 ratio around 150 to 200, we can choose non-invasive ventilation. We prefer using the BiPAP, but we need to be careful about BiPAP because the tidal volume and high respiratory rate probably will worsen the lung injury. Also, we need to evaluate patient response. We calculate, we followed up the tidal volume. So if the tidal volume is the more than 12, and we probably stop the non-invasive ventilation and intubate the patients. So if the P4 ratio less than 150, and probably we are intubate the patients first. And of course, we need to test if the patients respond to the lung recruitment maneuver. So actually, I don't think that is work for our patients because we cannot set the high PEEP. The highest PEEP is around 20 for the lung recruitment maneuver. So also we calculate the driving pressure. We monitor the driving pressure, and we try to maintain driving pressure less than 15. So if not, and then we will paralyze the patients with wrong position. Also, we need to follow up the lung compliance. So if the patient condition still worsen and with the hypercapnia and the acidosis, probably we go to the ECMO for the patients. So here I will share a case for you. So this is the 64 years female transferred to ICU from outside hospital due to the severe hypothermia and tachycardia. And actually she received corticosteroids and antiviral medications for for 5 days or 7 days. She also received the non-invasive ventilation for nine days. So this is the chart for her in the last 9 days for the non-invasive ventilation. So you can see actually her respiratory rate still worsen, still very fast, and the saturation still not good. And when she came to our ICU, she's very sick with the tachycardia and hypoxemia. And we prepare intubation for her. And also we check the arterial blood gas. So she has acidosis with the carbon dioxide retention. Also, her PIF ratio quite low, less than 50. And we intubated for her and using the small tidal volume ventilation, and we try to adjust the PIP and to control the drum pressure. Actually, her drum pressure is still high, and we subsequently paralyzed her with the prone position, but her condition still deteriorated, and the PIP ratio going down. Also complicated with the hypertension, requiring high dose of vasopressors. And then we switched to the ECMO for her. So this is her echo. Actually, we do the echo for the patients in the ICU regularly. So actually, you can see her right ventricle become enlargement, her left ventricle compromised. So why her was the hypertension requiring the high dose of the norepinephrine, because she developed with the acute cold pulmonary, which was induced by the severe hypoxemia and subsequently pulmonary hypertension. So after ECMO treatment, so her condition improved. You can see her echo. So the right ventricle or left ventricle almost back to normal. Also, her norepinephrine going down from 1 to 0.3 micro per ml per kilogram. So her condition improved with the oxygenation. So actually, she gradually recovered in the ICU. So this is her chart from the ECMO. So gradually improved. So we finally went off the ECMO. So in the day 10, and also switch to the ventilator. So still around take another 1 week, gradually weaning from the ventilator. So finally, she weaning from the ventilator. Finally, she discharged from ICU, discharged from hospital. So this is the lesson we learned from this case. So the long term of the non-invasive ventilation, so probably worsen the lung, and we need to be careful about the acute cold pulmonary because this is always complicated with the severe hypoxemia and hypotension. So this is induced by the severe hypoxemia and subsequently pulmonary hypertension. So if we can improve the hypoxemia, and then we can improve the pulmonary hypertension, and we can improve the acute cold pulmonary, and we can improve the hypotension. So this is the flow chart for the ventilation support in our department. So we, based on the PIF ratio.
Dr. Pong?
Yes.
Yeah, Request for voice increase, please.
Okay, okay.
Yeah.
Okay, sorry. Okay, so this is the our flow chart for the ventilation support in our ICU. We choose the different models of the ventilator based on the PF ratio, and we need to change. We need to evaluate the patient's response to the different models of the ventilators. So, in conclusion, the critical ER patients affect the older patients with much more comorbidities. So, preparation of the PPE and the practical protocol during the intubation is important to our medical workers as well as the patients. And the prolonged pre-oxygenation and the bolus of fluid or vasopressors using were required to prevent hypoxemia and circulatory collapse during intubation. So titrating the models or parameters of the ventilation supports with long protective approach is crucial. The most common complications was ARDS, arrhythmia, and septic shock. Nearly half of the patients requiring intubation. Okay, thank you for your attention. Thank you, inviting me. I'm happy to take any questions.
Great, Dr. Pong. Thanks. Dr. Joshi, you can also unmute your line. So now I request Dr. Joshi and Dr. Pong to discuss among themselves regarding the topics of their concern. And next phase, I have a few questions prepared. I will be asking them one by one. And at the last, we will have the audience questions. Okay. So
Okay.
over to Dr. Peng and Dr. Joshi for the discussion, please.
Okay, thank you.
Mhm.
Good of Peng.
Yes.
Can you hear me?
Yeah. Yes, I can.
Can you take the screen off from us, please? Yeah, that will be great. Yeah, Peng. Yeah, nice seeing you, and a lot of hard work from your side at Wuhan. Congratulations. Let me put it before even express anything at this stage.
Thank you.
Peng, actually, I had discussed with a lot of my friends and colleagues in India. What was being asked is how did they manage such a flow of patients at your place? Did it come like about like 3 patient, 4 patient per day? Did it come like 30, 40 per day, or 100, 200 per day? That's what they appreciate the effort that has gone through it. How did you manage this kind of great task?
Okay, so sorry, I cannot hear you clearly. So would you mind repeat?
Oh yeah, I think this is the maximum I can speak probably.
Okay,
No,
so Dr. Peng and Dr. Joshi, probably I can intervene in
Yeah,
between.
please.
Yes. So, Peng, the question is about patient inflow.
Yes.
Dr. Joshi is inquiring,
Yes.
how did China manage patient inflow of such high volume?
Yes.
Okay. Yeah, this is the very good question. So, actually, we run the screen test for the COVID-19 for all the patients, whether or not they are elective cases or they are emergency cases. We run the test, including the PCR, including the serology test, and we will try age. We are try age these patients based on the results. So if the patients was considered as the COVID-19, and then we will move this patient to the specific buildings. If the patients is still waiting for the results, and we will put the patients in the buffer area, and to also waiting for the results. And if the patients were now considered as the long COVID, and we just labeled this patient as normal cases. So based on the results, and of course, we need to run all the screening tests for all the patients.
Yeah, just next one, I just want to ask how many beds really they had in that Libya province, to take care of that huge road. That's not a small thing, because subsequently they constructed the hospital and all in 10 days. That's a different story. Can you ask that one?
Yes. So, Dr. Pong,
Yes.
we heard that many new beds were added and some cabin hospitals came up in Hubei province. How many exactly beds were required for such cabin setups, such hospitals?
You mean during the outbreak or now?
During the outbreak, when it
Yes,
all
yes, yes,
started.
yes.
Or during the outbreak? So actually, we have one specific hospital, which is called infectious disease hospital, open only for the for the COVID-19 in the early stage, which is around only 1,000 medical beds. But unfortunately, was not enough for the for the patients, for the COVID-19 patients in the early stage. So we had to open other hospital, especially for the teaching hospital, to take all the COVID-19 patients. So actually, we almost opened to around 20,000 medical beds from the general hospitals totally, and this is only for the patients, which is called hospitalized patients. Also, we opened the temporary hospital for the mild cases, just just to follow up the patients, because we cannot quarantine the patients at home. Because in China, the the apartment is quite small. We have no enough space for the patients to the home quarantine. So we opened the temporary hospital, such as the theater, such as the the sports center, for the for this kind of mild cases, just to follow up, just to let them just not allow them affect the other populations. So around about for this kind of the temporary hospital, almost around 10,000 or 10,000 to the 15,000 temporary hospital medical beds in the early stage, during the outbreak.
One last question, Frank, from my side. One last question from my side.
Yeah.
I heard your press statement yesterday. Let me repeat. I heard your press statement yesterday from Wuhan province. I mean, so Hubei province, about the recurrence of patients, and you had some group and they wanted to do the screening tests for almost, I should say, 1.1 million, something like that.
Yes.
And
Yes.
you said it is very costly. It may not be practicable. That's what I heard. Correct me if I'm wrong.
Yes, because we just
No, I'm not at all. One more thing I want to know is, were the patients same as the previous patients, or are they new?
So actually we found I think we found 6 new cases just in the last 2 days. So this because all these cases, new cases, were mild cases. So we are still in tracking the people probably they have which have the close contact with these new cases. So from this point, so the government finally make the decision to run all the screening tests, in this city. So that's the one by one, just one by one. So first, do the screening test for the high risk of the population, such as the such as the the population from the medical staffs, or the the family members of the hospital hospital staffs, the family members of the patients, also the or any other or any other population which they have a close contact with the potential COVID patients. So just the one by one, just the step by step. So first for the high risk population. So then the government want to run all the screening tests for the whole city.
No,
so we have more than 12 million population in Wuhan.
Yeah, Dr. Peng, only one question is, are the new cases what you heard as some so-called positive, are they the old patient who became positive, or the new categories? The new patients, are they the old patients who got reactivated, or is it the
actually all the new cases they have a mild, they are very mild, no any severe symptoms, just the just the quarantine in the hospital, for the follow-up in the hospital with which is called the Jingyintan Hospital. This hospital is specifically for the infectious disease patients.
That's good. Thank you so much. Thank yeah.
Okay, thank you.
So Dr. Peng, if you have any questions for Dr. Joshi and India specific, yes.
Okay, thank you, Dr. Joshi, for your excellent talk.
Thank you,
So
Dr.
actually, I'm also concerned, probably after the COVID-19 outbreak, everything will be changed, in our, not only in our routine practice, but also from our routine social life. So do you have any experience, in your hospital? So how do you triage your patients daily? So such as because you have, for example, if you have the emergency cases, how do you triage this patient is COVID or non-COVID? So if and how do you make the decision? So how do you put the different patients in the different facility or in the different building, in the different ward?
Thank you, Dr. Peng, for information, and thanks for your excellent lecture. And also, we learned a lot from what you went through at Wuhan. In fact, what we're observing, the difficulties, what you faced, and also that was, say, yours was the first exposure.
Yes.
Wuhan was hit pretty badly. Let me put it. It could be me, it could be you, it could be the panelists who are sitting here. And you handled it to the best of your capacity and your understanding of the illness, what was happening, nobody knew what was hitting whom, why. So with all those things, we learned now the question strategy, what to be followed the hospital is. Don't ignore any complaints, because at that time, when probably this was about 4 months back, the thing was I thought it could be predominantly aerosol kind of thing. At that time, I don't know about, that's what we heard from the initial inputs what we got and all. It could be aerosol kind of thing, from the whatever the there are a lot of discussion from where it came and all those things, and back to human and all those things. Initially, it was projected like a aerosol. Subsequently, they said that the virus is found in even probably the GI thing also. Then they said the peritoneal fluid also. Then somebody said CSF also. Then it became it can come from so many places. Doesn't have respiratory pathogen. It was projected like respiratory pathogen, but it's not. So now what? Any patient who comes, and probably you look at it, because the incubation period they said 1 to 14 days. So technically, most of people, they know about it because India is still under lockdown. We don't have we do not have the full population who has come out of the whole lockdown, coming to the main circulation. But still we are watching what are the variations which are there. And probably one thing we did not get much information from Wuhan, the thing is two groups, actually kids, we did not know how exactly they are presenting at Wuhan. And pregnant women, difficult. I'm not expecting that we wanted to know from there. But predominantly it was more like aerosol kind of thing. The people took precaution. Now what we do is we look at the probably who showed symptoms and all those things. Thinking biggest problem is the limitation of getting the testing kits. And suddenly somebody and false negative is almost 30%. That's what we say. RT-PCR. If false negative is 30%, then we have to look at if somebody negative today becomes positive 3 days from now. How do you take it from there? So still we are. I would like to say the lockdown phase we are coming out on all. Actually now we are looking at like easing of the thing, and probably the kids are more. These 4 months probably I should say, like the classical from Chinese saying, the bamboo tree doesn't grow tall initially. First 4 months it develops only its roots into the soil. Subsequently the tree grows. So first 4 months India was doing same thing, allowed the roots to go in deeply with all the experience. Now we are looking at it can present in different ways and all. We take it, we respect the way it comes. And what I look at is at this point of time is treat everybody as suspect COVID. So there is nothing stigma kind of thing about that one. Like suspect COVID, and it can present in diverse way, educate the people and take it about. And it's not like it's not like pathognomy compared to HIV, HPV, like lifelong stigma and all those things. You just have to tide over the. That's why I asked you the question about the new patients. What you had at probably South Korea and maybe China. Was it a recurrent second wave, or was it a new group of patients? Because I studied one more thing from China that I don't know, maybe you can correct me, maybe I'm wrong. When you had the first patch, maybe earlier, maybe I don't know, October, November, something like that. This all from what we read from the WhatsApp knowledge. Could be wrong. 99% is wrong, 1%. And I believe apparently the virus was injected into some monkeys. Same virus, what we got, human got affected. It might be wrong, but the thought seems to be good. And after 14 days, maybe some of them they died, some of them survived. Who survived after 14 days? One more inoculation was given. But this time they had a very mild. After 14 days, one more inoculation was given and all. So idea of asking was whether the patients who got reactivation, so secondary wave what you got, was it with new patient or old patient? Was if new patients they got it, then we have to look them at a new group. If it old patient who got it, in case they showed mild symptoms, that means there's something called herd immunity which might be developing. I'm wrong, you can correct me. Dr. Pang, your thoughts.
Sir, Dr. Joshi, I think Dr. Peng, yes, will continue. There was a specific question, triage.
Yeah.
How are we going to adopt in emergency the triage specifically? That's
triage point of view, it all depends what we are following in India right now. Like now, we are also almost now, for example, India recorded its first case in I think it's on January 30th. First case we got January 30th. We went to lockdown around March 24th. You can say almost 2 months after the first case and all. But like what a patient comes and all, like one week I got community surveillance also in which a patient, we have specific COVID hospitals. Once the lockdown announced, all the elective surgeries, all the hospitals were closed. Only some hospital directed only as COVID hospitals, and all the patients were streamlined to that COVID hospital only. So they were doing the triage with respect to depending on symptoms and all those things because the kits were limited. We couldn't expose the entire country for the whatever the tests and all those things. Every city, every town had a kind of a COVID hospital. All the patients were sent to that particular place, and irrespective of whatever the complaints they had, any suspicion of fever, respiratory infection, and subsequently by then it could different symptoms like GI also, or probably primary contact, secondary contact. Everybody was screened, and all the surveillance, and then they were kept under observation. And as per the merit of their complaints and all, they are put on only observation or observation with oxygen supplementation, or probably with ventilation and all. Probably at the end of all these things, we are sitting around maybe as of today about 74,000. I should say about the infections. But then probably we might overtake China soon.
So actually, in Wuhan, we have the triage policy in the emergency department. So I just mentioned that we have to run the nuclear test for all the patients. So at least for 2 times. So including including the PCR test, including the serology test. I mean, at least for for the 2 times of negative result of the nuclear test. So after 2 times nuclear test, negative test, and then, okay, this patient will be clear from the COVID-19. So, and during this process, we set up the translational zone in the area, support this patient in this area, and we set up the all the PPE, all the policy. So we consider this kind of patients as the potential COVID-19. So after we got the result, and then we will triage to the different area for the patients.
Dr. Peng, I fully agree with you, because luckily for us, probably the Wuhan province was the example for us. Already he had done the groundwork for everybody on this planet. So our job was only to follow or modify whatever we can add and all. So before even it came to the India and all those things, so most of the places already we had a COVID hospitals or dedicated hospital or this thing. The triage very clearly who is positive, who is negative, who is suspect. So it was kept separated, like who could be suspect and who could be positive, who could be severely, who might somebody might present like a SARS kind of thing, SARI kind of thing. They might just come like that. So on that basis, people were kept on segregating, but it was kept on under observation, because we are like getting new information from other countries also. By then, Wuhan had slowed down, and probably the other countries like Italy, Germany, France, so they were in their thick of action, and it was the presentation was slightly different. We had some people coming from outside the country, like our own, like I should say our own countrymen who came from other places because they had gone a job or something. That's fair enough. Nothing wrong about it. But every patient who came and all those things, water complaints they had, the biggest problem sometimes what happens, because of stigma, some people did not tell they had this problem. That's what I told in my lecture, like about that one, like with smallpox, this was not a problem because it was obvious on somebody's face. The smallpox person couldn't hide his face, but probably I should say COVID-19 person, he can be asymptomatic carry for 14 days or 10 days, whatever. The smallpox person, no, it was obvious on his face. That's why we could. So quarantine was quite successful in smallpox and all. But here, in that comes to this particular asymptomatic. Now, what do you do if 85% people asymptomatic people will get infected? 85% they recover. Another 10% they might go to hospital, they might require, 5% might require ICU, or 2.5% might die. So it's very difficult. This is more highly infective. So let's I should say about I should say like moderate point of view, but compared to what it was 100 years back in 1918, where loss of life was different, but now 100 years down the line, we look at every life is very valuable. We can't afford to lose any life. So that is the whole strategy, what it changes. But we are not still out of all this thing. We are still understanding the pandemic as it goes. It takes 2 to 3 years. I told there may not be safe exit for any of us. It could be messy affair, and people might just come out on the street. Look, let me accept whatever it is. But even a vaccine. Oh, one more thing, Peng, I just want, even vaccine has to come. It has to take at least 1 to 1.5 years to complete whatever trial that might be required. I think so. I think so. I think so. What about the medication? Any medication you think it made a difference for any of these patients? Peng?
So actually, from my experience, I don't think so is any medication useful for the for this virus, for the SARS-CoV-2 virus.
Vaccine?
Yeah, vaccine probably, but we need to wait at least one year.
So my take is it might take at least another 2 to 3 years. Is it yes or no?
But but probably
overall things to settle down.
Yeah, probably the virus is always mutated, always changeable. So it's you cannot guarantee the vaccine how long the vaccine will work for the patients.
It's tough, Peg. It's tough. It's not so easy. I know I'm sitting as a a critical care chief over there, it's not that easy
Not easy.
for you.
Not easy. So do you think the the hot weather can cure the virus?
When actually weather-wise, it has not made difference. One thing, let me put it other way around. As I'm seeing it now, or probably rather, I'm like listening discussion and all. Like there are some countries who never had this quarantine. You know about that one, like
Mhm.
Switzerland. I think probably correct me if I'm wrong. Then Switzerland, but they opened and they allowed it to happen and all. I think all the countries are following so-called lockdown on the basis of at what time they can really handle the pandemic in a better way, because they like ramp up the health infrastructure and the people, beds and all. On that basis, we are increasing the lockdown, not just because we want to increase lockdown. Lockdown is morbidity, is the question. But question is it what every country is looking at it, how best they can handle that particular one. But Switzerland is managing, and some handful of islands in Pacific. You know it much better than me, close to Australia, New Zealand, and they don't have a single patient.
Okay.
Peng, I have a different question for you.
So
I have a question. You're not over.
yeah.
Yeah, about air conditioning. What do you think?
Air conditioning. So
Yeah.
actually we turn off the air conditioning, for the during the outbreak of the COVID-19. So because this is the potential resources for the transmission. Yeah, we
Peng, one more thing I want to hear from you. What about the scavenging system
mhm.
of the operating room? Scavenging system. You're an anesthesiologist. I'm exploiting completely.
You
I'm
mean-
exploiting you. You're an anesthesiologist. What about scavenging from the OT? Can you use central section, or you want it to modify?
You mean for the in the OR?
Yeah, absolutely. Don't
Okay,
tell me I don't know. You're an anesthesiologist.
Yes. Yeah. Yes. I'm yes. I'm an anesthesiologist. Yeah.
Yeah. Now, what about the air conditioning? Do you want a negative pressure or a normal pressure?
Yeah. I mean, if the OR can equip it with the negative pressure, probably it's okay. For it's good for the for our medical professionals. So I actually I highly recommend in the we at least prepare one room of the OR in the OR for the COVID patients with the negative pressure.
No, Peng, I have one solid question for you. The question here is, we probably both of us working in some institutions. We are lucky. Say I have 10 operating rooms, I can spare 2 operating rooms only for COVID work. In a small unit which has got hardly 1 or 2 theaters, how do you guide them? What they should be doing it? Air conditioning and scavenging.
Okay, sorry, I cannot follow you.
I'll tell you again.
Sir,
You and me are big hospitals.
Yes, because
We can spare 2 operation theaters for something. COVID-19. Only COVID-19 cases will be done there.
So anyone?
So, Dr. Peng,
Yes.
If I can intervene, Dr.
Yeah,
Joshi
please.
is asking. Yeah.
Yes.
So, Dr. Joshi is asking
Yes.
if we are all in big institutions, like Dr.
Yes.
Joshi is working in a big hospital, you are
Yes.
also a part of big hospital.
Yes.
Can we convert the whole hospital into a COVID-19 setup?
No.
Okay.
Because we just open one building or open 2 buildings for the COVID-19 patients. So we need to keep other buildings for the non-COVID patients. So and because in our hospital also we just one of the biggest hospital in Wuhan. Also is the teaching hospital from Wuhan University. So during the outbreak, we opened almost half of the facility, half of the buildings for the COVID-19 patients. Also, we keep other half for non-COVID patients, where everything totally separate from the COVID and non-COVID. So including all the, including the, the CT, including the, the lab test, totally separate. But we cannot, because we have to serve for other non-COVID patients, even during the outbreak of the COVID-19.
Yeah.
Especially for the emergency cases.
That's great, Peg. Yeah, Deepesh, yeah, please go ahead, Deepesh.
Right. Sir, did I understand your question right, Dr.
No,
Joshi?
that's okay. That's fair enough. That's fair enough.
Okay.
They are different model. Yeah.
Okay. So I believe after this discussion, we can again come back to similar discussion. I have a few questions already ready for Dr. Peng and Dr. Joshi.
Oh, great, man. Please go ahead. Yeah.
Okay. So first question, I believe Dr. Peng, there is a lot of interest from Indian audience about China for obvious reasons. And same thing, I believe from audience in China, we can also see how Dr. Joshi can take up about the matters which are there in India now. So on similar lines, I think the first question to Dr. Peng is, does the BCG vaccine have any protective qualities against COVID-19?
So actually, I heard that story because I heard the different population infected in the States. They told us. So some Asian population, especially the Chinese immigrant. So actually, the instance of the COVID-19 in the States, from the Chinese immigrant actually quite lower, because they calculate probably this Chinese immigrant they have the the vaccine when they were in China. So I think probably this will boost the immune function to against the for the COVID-19, but we have no any strong evidence to show this relationship, because in China everybody have this vaccine already, but we cannot compare. But in the States, actually, they do have the data. They told us the Chinese immigrants probably the instance is quite low, because they have such the vaccine before. Probably I cannot show this is the relationship, or this is the any other because we have no solid evidence to explain that.
Okay, I understood. I think it's a US thought that probably BCG is helpful, but we do not have scientific evidence to prove. Am I right, Dr. Peng?
Right, yes.
Okay. So next question is to our Dr. Joshi. So, sir, when should we start the elective surgeries now? In India, the situation you know. So elective surgeries.
Yeah, sorry. Peng, anything?
No, sir,
Peng,
you can
anything
continue.
you want to add?
Yeah, Dr. Peng, if you want to add anything.
Yeah, you mean the when should we resume the elective cases, right?
Right. I'm asking this to Dr. Joshi for India, when the elective surgeries can start. Yeah.
So actually, in Wuhan, we started the elective cases just in the early April, because during that time, almost zero new cases for for almost 2 weeks, and then the hospital authority so determined to resume the elective cases during that time. But this is a very difficult difficult time. So we need to prepare for all to reopen the elective cases. So first we need to clean everything to prepare the environment. Also we set up the policy, the protocol. Just we mentioned how to triage the patients based on the results, based on the PCR result, based on the serology result. because this is quite important. When we determine to open the elective cases, we need to we need to do the best job for the triage for the potential COVID-19 patients.
Yeah, thanks, Dipesh.
Sir, I think you can also continue. Yes.
Yeah,
Thanks,
yeah.
Dr.
Thanks for Peng. Actually, what I can understand, what I know about that also, like I think Wuhan was under lockdown for 76 days. Am I right?
Yes, yes.
That is that you finished on April 6th or 8th.
Yes, yes,
Right?
we almost resumed.
April first week you said April 6th or 8th you finished. I remember.
Yeah.
Then you start electives.
Yeah, we resumed the elective cases for almost 1 month.
So actually, what is being actually suggested by the different, probably I should say, the societies across the globe is, what is at least 14 days should be there, where there is a dip in the number of the the incidence of the patients or the death, whatever you say, like number of cases or deaths and all should plummet continuously for 14 days. That means you are going down probably, and all those things, the pandemic is slowing down, and that is the time they say you can go for the elective one. But again, there is one more thing, is a lot depends on your authorities, because sometimes you lock down, as long as you're on lockdown, things are fine. The moment you open it up, again it opens up. So having said that, but does it mean that you can have been locked down for 6 months or say 1 year, 2 years? It won't work like that. I think electives, best thing is, what best suggested technical and medical point of what we can suggest is 14 days continuously. If the numbers are going down, death or the new infections, that's the time to start the elective work. Dr. Peng, anything you want to add?
Yeah, so actually, why we choose the the early April for the day to reopen for the elective cases, because during that day, almost 2 weeks, no any new cases. So this is the the government, the hospital authority, to have the discussion with the expert and to determine, okay, that time we open the elective cases, probably is the relatively safe for all, for the patients as well as for the medical workers. And also, of course, we need to prepare, for the reopen reopen the elective cases. We need to prepare. We need to the policy. We set up the protocol, because we need to do all the screening tests for the patients.
Yeah, Peng, I really noted your thoughts on all those things. As probably, I think probably what we are watching, like the AC recommendation across because I think the best authority will be the local authorities. They know how many kits, because it's not only about the 14 days from the country dipping and all. You have to know how many ICU beds you have got. You have to know how much is the manpower. You have to know how many PPE kits you have. Can you take care of all those things? And in case if you require the COVID testing and all, or equipped for all those things, then you need to have the priority, whether you want to go for the transplant patients or you want to go for the cardiac surgical patients or oncology patients. There are so many factors which are involved. But one simple thing guideline is, like, if resources are optimum, then you can go for the elective work. The reason being why you can go elective but later date, only reason being the outcome has been for people who are COVID positive. As of now, but things might, because as I told in my lecture, 14,000 papers have come in last 4 months. Even one person, one paper per day, is going to take 1,400 days. Let me correct myself, 365 days in a year. So that almost comes to you can imagine how much of time he's going to take for 365 days in a year. If you 14,000 papers, so much of information. Safest bet, government and available resources. If you are comfortable, you want to start, make sure the COVID testing is available And if you don't COVID testing enough and all those things, have enough PPE kits. Test kits are available. Get it done, and then if it's positive, let them go through cycle of recovering, going through all the quarantine and all those things. Then you can consider for the procedure. Dipsat, did I answer your question?
Yes, sir. I understood. Like if the
Yeah.
resources are there, as per Dr. Peng and Dr. Joshi,
Yeah.
then we can start the electives, and probably after a time of 14 days under observation, if the government decides so.
Yeah.
Yeah.
Oh, yeah. Everything's okay. Your resources okay. Your should be make sure the patient is safe. Make sure
Correct.
the medical workers enough they have enough everything
PPEs.
to take all the
Correct.
patients.
Correct. Okay. So next question to Dr. Peng. Dr. Peng, how about the reinfections which have happened to the patients who got infection first time, and then probably the reinfections happened? What are the effects of antibodies, and what is the duration after which this reinfection usually happened?
So first, we need to define what's the definition of the reinfection. So if the patients only have only like the 1 or 2 times of negative PCR, and then have the one more positive PCR. So we don't think this patient is the reinfection. So because probably the one negative PCR probably is the false PCR results, not the true PCR. So if the patients have the at least 5 times negative PCR for a long time, for example, for almost 1 month, and then when the patient came to hospital again, and then they do the test with the positive PCR, and then we consider that patient probably is the reinfection. So this is the different definition, very important, and also how we manage the patient with the reinfection. So just to follow up the patient, most of the patients with the reinfection, first the instance of the infection is quite low. I cannot say how much but from our hospital data, probably it's around 2% of the patients, probably have the reinfection. So, and also we follow up this kind of patients as almost all the patients, just the mild or just mild symptoms or asymptomatic. So we just follow up the patients. I just follow up the patients, every 2 weeks or every 1 month for the nuclear test to see how the patients the nuclear test changes, or any serology test or any antibody occurred. So just the follow up of the patients, and from all the data from our hospital, and I think it's some of the patients with the reinfection gradually, they become elective, become elective again. So without any treatment.
Okay. Okay. So next question is to Dr. Joshi. Sir, in India,
Yeah.
what are the new social and emotional problems for healthcare workers, especially in these tough times?
Not just, I think India, it's across the globe. I think Pengil also will agree with me. See, the question here is just a healthcare worker goes to a hospital. Just imagine, like, they're probably slightly more knowledgeable, definitely, than compared to the common civilization. You lockdown, you go to the work and all. Now, you don't know whatever the gloves you're wearing or probably whatever mask you're wearing, it's the complete seal or not, you don't know. Because I think Peng will agree with me, in Wuhan itself. Peng, am I right? If you correct me if I'm wrong, almost close to 2,000 people we lost, health workers at Wuhan province. 2,000 health workers we lost because we didn't have the safety precautions and all, either they did not follow, or there was some lack or overworked. A lot of them, they made a lot of efforts at Wuhan. Until that was the, I should say, like, the incubator for everything. Almost 2,000 people lost their life because they wanted to help the patient, save the patient. In the process, they got infected and they lost the healthcare personnel. Same thing applies here, because you come to the workplace and you wear the whatever the doffing or whatever donning you want to do, what are the mask, what are the hand wash. At the end of the day, you don't know have enough hand washing properly. Unknowingly, I have touched my mask, and I don't know I have touched my phone. And when I go back home, maybe I won't hug my children, and probably the children might get infected, my family might get infected, and this is human. I don't say, like, see, people have worked in probably kind of war, epidemic kind of situation. War is different thing. Like, understand, like in a person war between two countries and all the same people die because of the hemorrhage or maybe fractures. A lot of these things. The infection something at the end of the day, if the person has to go back home, his worry is, am I carrying infection back to the home? One, at here workplace also they don't know. And second thing is, how we as hospital or healthcare professional, we treat a healthcare worker who got affected with the COVID. Like, if I get a COVID-19 infection today, say for example, how will my hospital take it? Will we take it, look, this is occupational hazard, he has taken it, will they take care of me? Or say, no, this is not proper care and all those things. That's why I got support. The fear is there because across the globe, the fear is the loss of job, a loss of esteem, and loss of family life, and it is not, it's human. Nothing wrong about it. Nothing wrong about it. We have to address this thing and keep on talking to these people. It's not question of doffing and donning. It's always question of what we call it, like, talking to them, like tender loving care. Like, talk to them, say hello to them, and it's nothing wrong. Like, you're not going to die, and nothing like that. It's just infection. It comes and goes. This reassurance almost will have to repeat on day-to-day basis. That's the only way we can motivate our healthcare personnel who are working with us. Yeah, Deeptesh.
Okay, understood, sir. One question to Dr. Peng. So, any comments on the role of supportive treatment in ICU, like CRRT, cytokine removal, pharmacotherapy? What is the role of supportive treatment in ICU?
I mean, for the CRT, so actually the instance of the AKI from COVID-19 is variable based on the different region. So actually in Wuhan, the total instance of the AKI from the hospital around less than 10%. But for the ICU, the AKI instance is around 20%. So about half of the patients with the AKI requiring the renal replacement therapy. So I do think that kind of therapy will works for the patients with COVID-19. And also regarding the cytokine removal. So this is based on the theory of the cytokine storm. So if the patients have the rapid changes of the proliferation, such as the rapid deterioration of the oxygenation, in also the patient with the complicated with the shock, or complicated with the multiple organ failure. And also we have a lot of the diagnostic approach to detect if the patient have the cytokine storm or not. So if the patient have the cytokine storm, the patient usually have the elevated ferritin. The patient have elevated IL-6 level or CRP level. And so in this situation, we may have some approach to remove the cytokine. So one approach, which is called hemoabsorption or hemoperfusion, which is the using a column with containing the absorptive materials to remove the cytokines. So we use the such as the chrome from the company from the Europe or company from China, and also we run some study. So it do reduce the cytokine levels, also do improve the organ function. So this is the one approach for the cytokine storm. Also, we use the monoclonal antibody to control the cytokine storm, but from the data, so probably we haven't seen any improvement regarding the monoclonal antibody for the cytokine storm. Also, we can use the corticosteroids for the cytokine storm, but also we have run some study for this kind of approach. It works for the cytokine storm using the corticosteroids. So this is the our approach, for the different supports for the patient in the ICU. Okay.
Understood. Okay. Dr. Joshi, actually, there is a request from Dr. Peng. If you have any more questions for Dr. Peng, you can ask them now. After day's work, he would like to leave in some time. And then, sir, we can continue. Sir, your voice is mute. Yeah. So then, sir, because of our audience.
I'm clear. No, see, I'm just question here is not from my side. I wanted to get, I got it, and I'm just exploring other people in case they wanted to hear from him.
Correct.
Just give me one. I think there are one or two questions and all.
Right. I have a lot of questions on that. So I will quickly ask them to Dr. Peng.
You can ask him that I'm free.
Yeah.
I don't have a better work.
Correct. So
ask Peng because it's a long day for him. Peng, please.
Correct. Yeah. So I will ask questions to Peng now, Dr. Peng now.
Sure.
And
sure.
Then after he leaves, we will continue.
Yeah, that's fine. That's perfect. I'm okay with it.
Okay. So Dr. Peng, my next question to you is, according to a recent UK report, it is suspected that there is some connection between COVID-19 and an unusual inflammatory syndrome in children in China. Any thoughts on that?
So, actually, this kind of cases are rare. I know most of the pediatric cases, they have the complicated. I mean, not only for the pediatric cases, but also for the adult cases, or complicated with the embolism, the vascular embolism. So, for some pediatric cases, they have the pediatric, they have the embolism, in the big vessels, and probably they will induce the sudden death for the kids. So this is the big issue. And so because for COVID-19, the hypercoagulation status is quite often in all the patients. So we routinely using the prophylactics heparin for our patients. And if the patients have the high risk of the coagulation, such as the dimer is quite high, and the patients have the DVT, and probably we use the therapeutic dose of the heparin for the patients. So I mean, this is the vascular embolism quite often in the patients. So you mentioned that for the kids, I know this kind of problem is I heard this story happened probably happened more in the States, happened more in the in the Western countries, but in China, because this kind of situation probably not so often, but we do have such as the vascular embolism problem in all patients, in all ages of patients, not only for the kids, but also for the adults.
Okay. So, sir, next question to Dr. Peng is, do you think the serum ferritin levels in COVID-19 patient is an early clue for COVID-19 infection?
I don't think it's only clue, because the the PCR, for the nuclear test, the PCR positive is the one of the clue for the COVID-19. So of course, if the patient have the positive IgM or positive IgG, which also indicated that the patient infected the COVID-19 already. So they have the curve, the curve, based on the time course or of the the PCR, when the PCR occur, when the IgM occurred, when the IgG occurred. Usually the PCR occurred earlier, and then the IgM, and then the IgG.
Yeah, okay. Uh, Next question is, in big setups, hospitals can dedicate operating rooms for COVID-19 patients. But what about small hospitals? They have very limited operating rooms. How can they dedicate those resources for COVID-19?
This is the big challenge for for the medical workers in the small hospital. So, I mean, depends. So if it was the a it was the outbreak time, probably just shut down all the routine cases, only for the COVID cases. So, I mean, if it was the just like our situation in Wuhan, as probably the small hospital only focus for the non-COVID patients, but they needed to run all the screening tests for the patients.
Okay. Next question is, how is the condition in Wuhan and Hubei province now? Because in news, people are seeing that there is some sort of reinfection. Also, there is some positive news that many people have been treated. So, from your view, how is the situation exactly in Wuhan and what can be the future situation?
So actually now the situation in Wuhan is I think is almost back to the normal, because all the the hotels, restaurant reopened already, and just yesterday we have some new cases, just 6 new cases. I think it's the new case less than 10. It's normal, for the for the Wuhan, which is a huge population. But if the new cases is around more than 100, and then I will suspect that probably we need to reconsider the do we have something to can improve this situation better. But if the new cases less than 10, I think it's normal. But actually we have very strict policy to quarantine all the all the the citizens in Wuhan. We have very strict policy. In the public places. Every public places we need to have the temperature check. We have to show the green card. We have to show the health card. For the to if we want to go anywhere, we have to show the health card, which is containing the information. How is our recent nuclear test, how is our recent serology test. So if you have the healthy card, you are allowed to go anywhere. I mean, so, and even in the public places, they have everybody have to have the temperature check. So all this policy make sure we have to control the new outbreak of the patients. So actually, in the Wuhan has reopened already for 1 month. So I don't think it's we have the second wave of the outbreak.
Okay, so next question is, as an ICU intensivist, what do you think of the current situation now? Is it early intubation or delayed intubation with oxygen therapy, which is better? Early intubation versus delayed intubation with O2 therapy.
So I mean, it depends. It's the whether or not we will perform intubation for the patients. We need to. I just mentioned that we need to run the screen test for the patient. So if the patient is long COVID patients, and then we just follow the protocol for the long COVID patients. So if the patient is okay, and then we can whether or not if the patients suitable for intubation, and we have to intubate for the patients. So so we cannot delay the intubation for the patients. But
Okay.
of course, we need to prepare the minimum protection. I mean, the N95 mask is the minimum protection for our medical professionals. So, so if you want to perform the intubation, also you need to wear the goggle, as well as the probably the eye shield during the procedures to prevent the potential infection, even the patient is diagnosed as long COVID.
Okay. Next question is around ECMO. So how exactly ECMO helps for patients who are positive with COVID-19?
So from our experience, ECMO, the mortality from the ECMO treatment for the COVID-19 is around 50%. So almost similar to the patients with the severe pneumonia, with other virus pneumonia from other etiologies. So, I mean, the main point is that we need to we need to initiate ECMO a little bit earlier. So if the patients have the severe hypoxemia, and also complicated with the carbon dioxide mutation, so we need to initiate the ECMO for the COVID patients. So I don't think it's any differences from the ECMO treatment, from other, long COVID patients.
Okay. Some people feel, there is a comment from some doctors that propofol needs to be used very less for COVID-19 patients. What is your thought on this, Dr. Peng?
So propofol also even for the intubation, we should be careful, because I just mentioned, from my talk, propofol will worsen the hypotension because during the intubation, most of the patients are complicated with the hypotension. So we need to minimize using of the propofol for the patients. And also for the patients, for the sedation, also we use, especially for the patients have the using the the nutrition, the non the PN nutrition, and also we need to take to consider the the propofol will increase the the fat contents.
Okay. Sir, one question from non-COVID patients. In Wuhan, during the peak, definitely it would have been the COVID cases which were getting treated. But was there also a possibility that non-COVID cases also came in your ICU or in your hospital?
Yeah, of course. During the outbreak, we have the different building for the COVID and non-COVID patients. So even we have the ICU. Each building have their own ICUs. So yeah, we definitely we need to triage the patients in the COVID patients in this building, non-COVID in another building.
Okay. So, Dr. Peng, I believe it's quite late as you informed me. If you have any questions to Dr. Joshi now, you can ask. And then we will continue the session with Dr. Joshi. For our Indian audience, it is not very late now, but I believe in China, as you texted me, it is getting a bit extended, right?
Okay.
So, Dr. Joshi, please unmute your line, sir. We will have some concluding discussions between Dr. Peng and Dr. Joshi now, and then we will request Dr. Pengs for his kind advice further.
Yeah, it's nice talking to you, and I would love this. Probably this we could have ended we completed this session for some more longer time, but in a time frame is something and all. But we are learning from your experience. But we hope you don't have this experience again and again. That is the last one. At least within our generation, the next generation plan the way it want to do. And any probably you want a clinical pulse you want to share with us, like do's and don'ts. We always welcome you. Please share with us so that we don't do that mistake and then try to learn. Rather, we learn from your experience. Yeah, Peng, please.
Okay. Thank you.
Thank you, Peng. Thank you so much.
Thank you.
Thank you, Dr. Peng. I believe this was an informative session for both of us.
Thank you, Peng. Thank you. Thanks a lot.
Okay. Thank you.
Yeah.
Okay.
And we will continue the session now with Dr. Joshi.
Okay.
It was very informative, Dr. Peng, from your side. We heard a lot of new things from ICU's point of view. Thank you.
Okay. Thank you. Bye bye.
Bye bye.
谢谢。
Bye bye.
Bye.
Yes. So continuing with Dr. Joshi, sir, we also have a few questions around anesthesiology and per se hospitals as well. So I'll go one by one, and then we will take all the audience questions as well. As you rightly said, there are many questions.
Yeah.
So yeah. So sir, we already discussed about the social and emotional problems for healthcare workers.
Right.
Now, there is a stigma as well around healthcare workers, people who are going to hospitals for their regular job. How can India really come out of this notion of stigma? And what is your direction of thought?
This is see, the question here is being healthcare industry or otherwise also we have to understand it's part of the game. So look at try to understand about the fear. The fear with respect to it's not a stigma kind of thing. The fear like I might contract some infection from you, and a similar kind of thing. We had this problem with respect to HIV HPCG earlier about nihilistic injuries and all. It took some time to get over. And if you really want to be much more clear and all those things, like we had Ebola recently, as recently as about 2013 something or 2014 kind of thing. There's some one patient, sometimes like what happens, even the color of your skin also might attract other person to think that I think my audio is low, that's what is being said. Is it better now?
Yes, it is better. I can hear you clearly.
Nandita, मैं तो put Joshi audio is low. So,
Okay, yeah.
nothing wrong about that.
Now she's saying better. Now she's
But
saying
okay,
better.
fine. Yeah, possible. Now, what I'm trying to say is, we have to take it the way it is. I don't think we should find any fault with any person or individual. The stigma is going to be there. Say for example, if we were to be on, say for example, you have a computer with you, or maybe something mobile. I have a computer.
Right.
You have a computer with you, Diptesh.
Yes, right.
And
Yes.
all the 14 participants who are there, they also computer mobile with them.
Right.
So why are you having antivirus software with you?
You are right, sir. So to protect my
No, I'm
computer.
not right. Who's right here?
No. So to protect
Everybody's right.
ourselves.
Everybody's right.
Yes.
Everybody's trying to protect themselves.
Right.
That's human. The stigma is probably when I'm talking to the Joshis, whatever this thing I'm hearing from you or whatever I'm accessing, so-called the I should say the Zoom webinar or for that matter Mindray and all, it can infect my computer. Yes or no?
Yes.
So what you do? You take the antivirus protection, or you may not use the Zoom software.
Right.
So you think anyway different this from the pandemic?
I understand your correlation.
We
Dr.
respect.
Joshi, sir.
We should respect. We should respect. Yeah.
Okay. So, okay. Now, going to the next question, probably a question which is common to many. Will the cost of treatment go up? Because going forward, probably disinfection and all, PPEs, protective sanitization will be involved in everything. So, will the cost go up of
See, the
treatment?
cost is for your safety. You buy a computer, you want your personal data to be safe and all those things. For that, you buy an antivirus software. Yes or no? Hello? Pritesh?
Yes. Yeah. Can you hear me? Yeah.
So, yeah, I can hear you. So, question when you buy, you bought the computer and you are installing the antivirus software. Did anybody ask you to buy the computer?
Probably
So
from my
similarly, if
need.
somebody
No.
goes to a hospital for healthcare facility and all those things, for their safety, because the problem here is the outcome will be very poor if somebody is COVID-19 positive, if they have viremia. For that reason, we have to do certain testing and whatever. I don't know how often you check the your flight bill and all those things, the fuel charge so much, surcharge this much, safety charge this much, and all those things. Same thing at any hospital. So from where will they manufacture the funds to keep you safe, like so much of gloves, so much of masks, and keeping and all, and extra manpower and all? From where will they provide all these things? See, the people who give a computer to you, you buy the computer X. They say it's hardware only. The software you buy, software they give. For software you buy antivirus.
Right. As per my need, I have to.
Yeah, you got a point. If I buy a Mindray ventilator, sorry, answer workstation, do you have to pay for workshop? Do you have to pay for power supply also?
Understood your point. So as per the configuration increases.
Absolutely.
Yeah. Understood, sir. Okay. Sir, your next point is about telemedicine. You touched upon it during your presentation.
Yeah.
What is the future of telemedicine as per you?
It is going to increase. It is going to increase. The one good thing about telemedicine, whatever we say or whatever, I've been using it last maybe 16 years continuously. Nothing less than that and all. It's only for it. It is good for where there is no need for the physical examination.
Right.
History-wise, if I can make some like diagnose certain things, certain thoughts and all, it's fine. But if I have to go for the examination and all those things, it's difficult to telemedicine. But follow-up will be again good. Follow-up. Say, for example, if I'm a patient of say some clinical psychological problem, something like that, anxiety neurosis, something like that, then counseling on the system is fine. examination will be a difficult. But one thing we have to understand, probably everybody whoso is still there, is that vitals will be monitored through the newer software. Talk of the pulse or respiration or token. It is going to change. It's going to change. And even the blood glucose and all those things for which people have to make a regular visit to the lab, that also is going to change. And in your medical supply also, which you go to medical shop and like there'll be a drone which will be delivering the medications to you.
Medications, yeah. So do you think we are ready for such changes abruptly now? I believe for many, are we ready? Do you foresee us to take this up and accept it as a new normal very soon?
See, the question is early bird gets the worm. Who is getting the worm now?
Okay.
Got my point?
Okay.
The question here is you have to scale up your investments and your plan and your budgets. You have to put one foot ahead, 1 meter ahead of other people. Be ready for that. I am not ready. Okay, no problem. But somebody is ready.
Right. Right.
They'll walk away with about whatever the credits and all those things. But the question here is it going to make impactable kind of difference is the bottom line.
You're right. Yes. Okay. So, sir, next question. Like we see a lot of news that doctors who are handling COVID suspects, they are distancing themselves from their own families. It is really creating a tough time for them as well. I understand that probably they are doing it from safety point of view. But do you have anything as a comment on this?
I think, see, we have to understand the different group situations. Say, for example, if I were to be an army soldier and all those things, I go into the battlefront 6 months. Once 6 months or 8 months, I take a break from whatever if they permit me take a 1 month leave or something. I come back and I spend some time with the family. If things are conducted in the country, if they're emergency, then they'll call me back and all. But here also, whatever way it is and all, see, question, this is unanticipated. Unanticipated means there was nobody anticipated pandemic. So these things are going to be that mentally somebody is not prepared. Mentally somebody not prepared. And say, for example, how many
Right. Yep, right.
So each war, people have sacrificed themselves. Here also, the only thing is you go to the battlefront, you fight with people. If the bullet hits you, you're gone. But there are people who had only injury to just to make them disabled. Somebody had one leg amputation. Somebody had a right hand not working or left hand not working. Somebody had some bladder not working permanently. There are soldiers who got injured and all those things. It's not but question here is whatever the thing what it like in a pandemic conduct, people are not exposed, and that fear is there. Why me only? Why should I be suffering? Why not others?
Okay.
Right? Why not others?
Right.
Why should I be suffering?
Correct. I think it's a mutual thing about everyone.
But they know it's wrong. We have chosen profession by choice. Nobody forced us.
Correct.
As simple as that.
Fair enough, sir. Going on, next question is by Dr. Siddha S. Rao. Sir, what is your experience with hydrocortisone and low molecular heparin?
No, I know, Dr. Chakra sir, what is asking is like, it's putting fire and also ghee in same thing. Hydrocortisone low. Because pathology is still varying from, I should say, about where we thought it's only acute viral this thing causing, and subsequently we're talking about what is called as thrombogenesis, and you want to add heparin for that one, and to open up the thrombosed vessels, and again you want to have like a steroid which can create bleeding on its own because stress. It's too early. It's too early for any of us to comment, because I told you, even the 14,000 papers are there. It takes some time for a paper to come to compare and contrast. You need to say one group I give hydrocortisone, one group I give low molecular heparin. Who improved best? To say that you need some control and some cohort. So nobody is sitting here like a Baba kind of thing just to say that like this work, that doesn't work. If we knew all those things, probably there are no need for this discussion, this webinar at all. Thoughts are good and all, but I told you 14,000 papers are there working about that. A few papers might be supporting, few may not supporting. We have to look at the pros and cons.
Sir, we discussed it earlier as well. Like the virus is mutating and it is changing its form. So some strains are probably more viral, some are less viral. How do you see this? Even if there is a vaccine, probably it will work on few groups of people. It may not be effective as a blanket solution. And also the medications, there is a limitation. So how can common man really try to see a end of this tunnel and see some light of it?
So now you're asking me like a visionary.
Sir, but this question you also, I think, discussed
No,
with
Diptesh, I didn't know.
Yeah.
In the later sense.
Okay.
No, I made a confession at that time. If I knew the answer,
Yeah.
I would not be in this particular forum. But let me make it very clear and all. Not to get depressed. Not to get depressed is the bottom line. I would like to say, see, at least now I think, Diptesh, correct me if predominantly we have Indian crowds now.
Predominantly, yes. We have our
Predominantly.
HQ. Yeah.
Predominant. I'm not saying.
Yes.
See, last 2 decades we have surplus food production in India. Let me put it very clearly. And a lot of the food grains are there in here and there, and we are using it for the people and all those things. It's fine. And even the pandemic continues for and all. But I told you, like, the closest family for this one COVID-19 pandemic happens to be 1918 influenza.
Okay.
It took 2 to 3 years for things settle down.
Okay.
Right?
So this is much more dangerous. So
No, not much more dangerous. So that time, people were dying at the age of 17 to 20 years. Got about because that people the life expectancy was much lower. So people were dying at much younger age. Sailors who will go into sailing and all, and soldiers, they were dying just like that. So it was happening at that time. But took 2 to 3 years. Even though you start working on the vaccine and all, it takes at least, but just think about what it takes about. If you are in farm industry, how much time will it take for vaccine to come? You tell me.
Sir, as you rightly said, I also happen to know that it takes
Normally,
18 months minimum under trial.
You're right. Minimum is 18 months.
Right.
So what did I say? 1.5 years.
Correct. It's the same thing. So
yeah,
we have no other choice but to wait, I believe.
About any molecule?
I think many years. It takes many years.
So we are clear about what we're speaking.
Right.
So it took 3,000 years for a vaccine to come for smallpox. Yes or no?
Yeah.
Right,
sir. Understood. I understand your point.
So it's same thing. So question here is, maybe science will evolve, technology will evolve, something new might come. But I'm just hoping that probably suddenly, unknowingly, probably COVID-19 might mutate into a weaker version. So we might escape. You never know. I'm not saying this is the way it is or that's the way it is. I think all the governments across the globe are working on that one. I think we have to respect their efforts and suggestions, and we have to work on that one. That's the only way we can come out of that one. And probably even individually, if you can contribute certain things, certain way. Say for example, even if it's about safety, social distance, and all those things, it's all buying some time, like lockdown. Till you find a final answer.
Okay.
See, that's what it's all said in the battle. Live for a day. So that you can fight it much better next day.
Yeah.
So live today by maintaining social distance and safety. Probably next day you'll be in a better position to fight again. But don't lose your life. Stay there. Okay. Maintain the guard. Maintain social distance. That's the way it goes. No general, no major had an answer for any battle anytime. He said, don't lose your life so easily.
Correct. Just safeguard yourself probably every day.
Dipesh, do you watch cricket?
Yes, sir.
Always the batsman told, don't lose your wicket.
Yeah. Runs will come.
Here.
Runs will come.
Same thing applies here.
Correct. Fair enough, sir. So probably our next question is towards donning and doffing of PPs.
Yeah.
Like
I
people,
think
yes,
Dr. Rajesh Gupta, I think probably.
yes. So people understand the different protocols around it. Probably there are many discussions around it already, which has happened. But still, as a practice, what do you suggest? What's the best way which people can remember and just follow it?
See, depends. See, where you're working. See, for example, now as of now, at that moment,
Hmm,
you are seeing so-called this webinar.
hmm,
I am sitting at my home and having a webinar.
hmm, hmm.
So, hats off to the technology.
Correct, correct.
The Peng was probably from his office or somewhere. It's fine. It's fine. It's okay.
Right, right.
So if I'm asking certain things about, say, for example, where should I turn it off? If we can afford an office at home,
Hmm, hmm.
I work from there. If I can't afford an office at home, sit home. So in case they can afford a separate area for doffing and donning, you go there. If not, see, I'll tell you very clear, Diptesh, you have some time? I got.
We have, sir.
So
Yes.
Diptesh, let me very clear, very clear. Forget about all the tests and all.
Hmm,
Imagine,
hmm,
tomorrow morning, the first case, whatever needs to be done. Ideally, or not ideally, the best practice, which is happening in different continents is kids are not there. You
hmm.
don't know who's COVID positive, who's negative. Yes or no?
Right, right.
Surgery has to be done.
Surgery has to be done. Yeah,
Yeah. So people are taken to operating theater.
right.
So everything is so only patient, two anesthetists, or one of the anesthesia consultant, one technician. Am I clear?
Yes. Minimum these people will be required.
Right.
Right.
So most senior person or most competent person will intubate the patient.
Hmm. Yes.
They wait for 20 minutes.
Right.
Aerosol to get absorbed
Hmm.
by the air exchange.
Hmm.
Right.
Yes.
After 20 minutes, other departments will walk in, surgery and
Mm-hmm.
anesthesiast and all.
Mm-hmm.
They do surgery. They get out.
Hmm.
These people extubate.
Hmm. Hmm.
Nobody will be there at that time.
No one will be there. Yeah.
After extubation,
Yes.
right?
So yes.
Take the patient to appropriate area. Suspect COVID positive, that will go there. Non-COVID, it will go there.
Hmm.
Next 20 minutes for cleaning and leaving it alone.
Hmm. Hmm.
No case taken.
Correct.
What do you think?
Sir, I think then the OT needs to be shut off, right? Like,
How many theaters do you have?
yeah, that's the biggest restriction. I cannot
No,
put.
I'll tell you. If you have 10 theater, this one. Even one theater also. Now you tell me.
Hmm.
Diptesh, how many trips you're going to fly in next 6 months from Delhi to wherever your destination?
It's not going to happen, I believe, sir.
Why?
Now, like, first of all, the service is unavailable, and also then there is a fear factor probably within all passengers that if it is not a
That means your question has the answer for my answer also.
oh, okay, okay. So I think
People are not coming to hospital out of fear.
yeah, to the OPDs the visits must be
They
very
will come.
less.
They will come. In case I got some tooth pain for last 3 months, I don't mind waiting for 3 months.
Okay, yeah.
So it's as simple as that. See, anybody has died last 2 months by not traveling.
I'm not sure, but I think not a majority, I guess.
Topic ends there.
Hmm.
The answer for the question here is you are indulging in a lot of things for no reason. So simply what I'm trying to say is things will settle down. See, to take for 2 to 3 years, not to panic. Things settle down, and government's working, research is working. I got 14,000 papers have come out in last just 4 months and all. It takes some time. Yes, somebody has an answer and all those things to utilize that particular services. You might have to pay the charge. That's
Charges,
secondary
yeah.
thing.
Hmm.
But at the end of the day, I think it makes a sense. Do you really require that surgery, or do you require that hospital follow-up? In case I got the same BP for last 10 years, same doctor I'm going there, it makes me feel better if you go and see him. But that's what I tell you in the lecture also. When I say about like the so-called Hippocratic oath, the human touch, how is the
Yeah,
touch now?
the touch is missing. Yeah, the touch is going to.
Not missing,
Yeah.
it's there,
Hmm.
but it's with gloves.
With glove. Yeah. The healing hands are changed to plastic hands now.
They're tied.
Yeah,
Things will improve over course of time.
correct.
Not to get worried, not to get scared.
Absolutely. Yeah. So next question is for emergency surgeries cases.
Yeah.
So any particular screening which needs to be done for the patients who are coming for emergency surgeries to the ERs?
See, there is no very clear-cut these instructions. If somebody requires emergency, whether positive or negative, is immaterial. See, for example, I'll tell you, route of action, bleed, hypertension, aortic rupture. Are you going to wait for HIV, HB stage, or are you going to take up in the OT?
Sir, I'm actually not aware of this.
You're not a medical person.
Yeah.
Because saving the life is important.
Right.
Who's positive, who's negative is a later story. Right? So same thing, emergency itself is a consent for that one. And you presume everybody is like in a positive, viral positive, you won't take up the work.
That way.
As simple as that.
Correct. You mentioned it. I think let's assume everybody.
Because already all the healthcare personnel across the country in India,
they are prepared like that.
I'll again say, they know how to handle infectious patients, especially NABH certified hospital or whatever this thing there. They know how to handle HIV, HPV patients. This is nothing great. Little bit extra response towards anesthetic side because of the aerosol. It's very important for us. Very aerosol point of view, about to use the box or use the plastic sheets or use the goggles or use the the face sheets. It takes some time to understand. You have to give some time.
That's a human psychological aspect.
Yeah,
as well.
nothing wrong about it. Nothing wrong.
Fair enough. So next question is around use of anesthesia machine in an ICU. So I believe intensivists are not really comfortable with such short span of ventilation which is provided by anesthesia machines. So in India, what are the practical challenges you foresee if there is any need to use anesthesia machine in an ICU?
So let's say the two things you have to understand.
Okay,
either Muhammad goes to mountain or mountain goes to Muhammad.
Okay.
Am I clear?
Okay. So we have to learn.
If your ICU is full, the patient has to go to a place where the ventilator is there and the ventilator is in the OT.
Correct.
You still want an answer or is it clear?
No, I understood. So we have to learn and upskill.
Absolutely.
Yeah.
See, and what are you talking about? All the newer water ventilators and all, they're back squeezers.
Correct.
As simple as that. So why do you worry about that? See, question here is you should understand most of the COVID-19 patients, the lung pathology is so clear. The most predominant accepted one is more towards the arterial thrombosis. So lung compliance is good. Whether you use with probably the OT ventilators or use with the back squeezer which are being manufactured by the different companies, it's fair enough.
Okay, sir. So next question is around, sir, COVID virus again. How is it different than the H1N1 virus which we saw? And I think statistically it infected many, but then there got a cure. So how different is the COVID-19? Because people are saying there will be a second wave and probably it will always be there with people in seasonal kind of an effect. What is your thought, sir, on this?
Deepesh, you heard of malaria?
Yes, sir. I've heard of it, and I think it's the biggest killer in today's terms for India as well.
So since how many years have been hearing about that one?
I understand. Okay.
So the question here is, whatever COVID-19 you are saying, 2-3 years it will go on and all those things. Mutation might happen this way, or you may develop some influenza vaccine and all those things. See, with the influenza or H1, this thing, whatever you are saying, or COVID-19, the biggest thing is about that one. No? All the time, wherever the disease is manifesting, like smallpox, I was saying, it's fine. Quarantine was possible. Where it was not, where somebody is carrier, and the benefit not obvious, then it's going to spread. The whole thing about COVID-19 is highly infective, but not less mortality. Compared to Ebola, which has got less infectivity, 50% mortality. Which one you want?
I think I don't want anything, but
Ah,
but yes, if there needs to be a choice,
but see,
yeah,
look at the positive side. Opportunities to
correct,
improve yourself.
correct.
Is there anything wrong about self-distancing?
Hmm, hmm, hmm.
What do
No,
you say?
there is no such thing.
Is there anything wrong about wearing mask?
I think it's for our own benefit. We should do that.
Is there
Yes,
anything wrong about hand sanitization?
that's the basic. Everybody should do
Okay,
it. Whether
what's wrong about this pandemic? It is correcting you.
sir, it is improving us as a human
Yeah,
being.
so
Yes.
it is better. You respect. See, it respect. But only thing is this penalty. There is no need to pay penalty. But
Yes.
when we don't learn,
Yeah.
somebody is going to penalize us.
I think it's Mother Nature who is
Absolutely, that's the only
ruling
Mother
us.
Nature who is improved. You know about the clips and all, but I did not put those things because I thought probably my slides were too long, so I
Mhm.
never wanted to put a single picture on my slide also. I'm sorry for that one.
No, great, actually, sir. I understood your point. We don't have a choice. We have to improve and probably uh, see what the guidelines are saying for our own benefits. The more fast we choose to adopt, probably it is for our own benefit, I guess. You are right, sir. Sir, next question is around air conditioning. You also posed a question to Dr. Peng. For smaller setups, is there any alternative in ICU where there is no possibility
See, the
of
whole
negative?
discussion of smaller setup only. It's nothing to do with the bigger setups. Bigger setups can afford. If I got 10 theaters, I can spare 2 theaters only for COVID work.
Right.
It's
But
bigger theaters not a big issue at all. The question is smaller. I look at
small.
smaller theaters. See, we
Hmm.
got this community responsibility what we are doing and all. See, one thing I'm very clear about that particular thing is, as per this thing is, if you have the test to clear, somebody
Hmm.
COVID positive or negative,
Hmm.
you do it. Negative, take it like what did HPCG, you take it up.
Okay.
In case you say that I don't have test and all, you treat everybody as positive. The way you did HPCG, needle
Hmm.
prick injuries and all.
Hmm. Hmm.
Simple.
Hmm.
So whatever theaters you got, what you can do is induce 20 minutes you wait.
Hmm. Hmm.
Then surgical team walk in to the procedure. They'll get out, extubate, 20 minutes you wait, shift the patient out, let them clean and take
Clean
it
them.
up.
Hmm. Hmm.
You might have slowed down for 6 months.
Hmm. Hmm. Hmm.
Deeptesh,
Yes.
tell me, last 2 months did it slow down or were you still fast?
Uh, I'm not sure, sir, but I think my life has
50%?
slowed down. Yeah. Yeah. Yeah.
50%? I'm not saying zero.
Yeah. Yeah. No,
So
it's not zero.
same thing next 3 to 6 months, we might have to probably see people may not come to hospital for elective work.
Hmm. 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 Correct. It will be all for compulsory.
So they will wait for some time, things settle down. That's a natural waiting period. That's fair enough.
Fair
That's
enough,
fair.
sir.
That's given time.
Okay.
Live for the day. Next day will be new beginning.
Hmm. Hmm. Hmm.
Don't have to rush through all the list. No, all the emergencies that had to be done is being done. Whatever the probably stroke patient need to be done is being attended. There is no history of. Tell me one thing, Dipesh.
Yes, sir.
How many people have died because of stroke because the doctor was not available?
I think if it is not reported within first 30 minutes, that's
No,
what I
so
heard.
I'm
Yeah.
asking about 24th or this 24th, about last 50 days.
Okay, sir, I'm not aware of the news of this kind, but I believe it is
I'm not aware, not aware.
less.
How
Yeah.
about I had a heart attack, nobody attended me. Next to nil,
Yeah.
next to nil, next to nil. I'm not saying.
I think, yeah, not reported much.
But
Yes.
obstetrics, there was people delivered on the road or maybe in the vehicle and here
Yes.
and there, right?
Yes.
And there are
Yes.
people who died on the road while walking back to their territory.
So, sir, are you suggesting that if we follow the normal slowed down version of our lives,
Yes.
are
Yes.
we going
Yes.
to?
But question here is whatever has to happen, despite all these things, everything is going to settle down. Take care of the
Okay.
pregnant women because pregnancy is something framed. 9 months, door delivery, it has to happen, it has to happen. People walking on the street and all this and dehydration and food and lack of those things are going to be there that we address. So there is no medical emergency at this stage to push yourself for too much thing except for pregnancy and maybe trauma. Now that we opened the road and all, everybody is bang, 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 bang. Those things, the trauma is going to be there. The stroke might come because of the old age, right? And the fall. Like you might get hip fractures.
Okay.
Age is going to continue. Hip fractures, stroke, these things. Of course, you will get the MI incidence more henceforth because somebody had a business loss.
Okay.
So those,
So
so
that's
you
why.
have to accept things. See, pregnancy and related, walking, dehydration and all, and the trauma at home, somebody fell down, and stroke because aging process. Those things are going to be there anyway.
Okay. Sir, we have only 2 more questions from our audience which are left.
Great.
I think the question is probably as an anesthetist to you. How are you managing anesthesia in remote locations of the hospitals like cath lab, endoscopy, radiology units? Is it in practice now?
No, see, of course, it's very clear. It's very clear. But I think that makes sense. Whatever because Asper is asked and all, to respect their thoughts and all. And see, the question is simple thing. If your hospital has the the lab test to confirm whatever the COVID test, like you got 2 tests, like about a polymerase chain reaction, like RT-PCR is one, tells about virus presence. Next, antibodies. So virus says virus you have it or not, and antibodies it says whether you had a virus infection last a few days or whatever, IgM or IgG. In case you have patient, all those things, if you have that particular thing and all, RT-PCR test, if it's positive, you know what exactly you have to do. But it's emergency, this thing. At the end of the day, if you have the positive result and clear-cut ideas, if you want to postpone, you can postpone if it's possible. Otherwise, you take it as an emergency and take all precautions. If you cannot postpone, every patient, you have to take it up. The simple is an emergency thing. That's a consent what you get in this pandemic, and take the precautions and then go about it. If it's not emergency, postpone. Simple.
Okay. So last one is actually a discussion from your side. People are asking, how shall we go forward if this lockdown ends? And as an anesthetist and as a fellow countryman and clinician, every aspect, what is your suggestions for all of us, sir?
No, my suggestion, my thought to all my colleagues and all, not that I am different and they are something different and all those things. I think it's difficult. See, institutions, it's not a problem. Especially, I'm worried about the freelancing practitioners and all. Like somebody says, I have posted so and so. The biggest challenge for us is 2 things. One is PPE not testing not available. Yes or no? First and foremost thing.
Yes, testing kits are limited.
Not limited. PPE not available.
Yes, people are struggling to
So
get.
basically, you are sending a soldier to the battle that we don't know who is the enemy and we can't provide you the gun, but you go and fight. What do you expect him to do? Ritesh, you got me?
Sir, I understood. Yeah, that's
See, the nation doesn't provide a testing kit to tell who is the enemy and doesn't got PPE kit, weapons, but you say you run the hospital.
It's very difficult.
But it's not only our country. It's across the globe. I don't say it's only our country. It's across the globe. So the challenge here is what we have to understand is who is right. How many people really require surgery? Say, like I told, like the colleagues are there. The cesarean, for example, with the due birth, what needs to be done. This thing needs to be addressed. There's no other option. But when you're doing any of this patient, you presume everybody is positive. Everybody, in case you don't have resources, send them to nearest center where they can do that.
Sir, we lost your
voice.
Risking
our healthcare professionals, because see, for one case you might become heroic, you might do and all, but subsequently that particular Taluk headquarters hospital might be quarantined for 14 to 28 days. All healthcare that get shut down, So many patients will suffer just because of one patient where we're emotional about it. But it's across the globe. Nothing special about India.
Correct. So, sir, now questions are over from my side. I believe you can all guide us to.
I know. I'm just thinking whether I finish all my questions, whatever things. I think
Please,
most of
please.
things.
We have covered. Yes, we have covered. I have
I
seen
think
it.
you're a Diptesh. See, but what I say, Diptesh, clearly, if I were to be you as a common man, this is what I'm trying to say.
Right.
If it's not required, telemedicine we have to utilize. But telemedicine cannot be substitution for all the things, because you cannot cook food by just watching TV, or maybe software on the computer, or maybe on iPad. Am I right?
Right. Right.
Things are so easy. There are no need for mother.
Mm, mm.
Can you get motherhood by watching any of the iPad or iPhone, something like that?
Absolutely no. Yeah.
Mother is mother. So
Correct.
same thing here. But at this thing, I think all of us we have to buy. See, that's where I spoke about history before I spoke anything. I think I'm sorry for Diptesh about the font being small, not because anything like little bit probably I should say about the thing, but when that was history. History you can always hear. Like I don't put probably like what I should say about the PowerPoint kind of thing. This thing, but that's okay. But history people have heard. You had when see it has taken 2 to 3 years for every pandemic. At
Mhm.
least flu point of view. We have to be ready for that one.
Correct.
Make sure live for one more day. Take care of your personnel at home, at hospital, and make sure they're comfortable. And take patients and all, and the patients are not in a hurry to come for surgery once they know that about what's happening around them.
Mm-hmm.
So they will also slow down, and maybe 6 months we'll have solution for all these things. That's one of the best of things. It will settle down.
Correct. Correct.
It will settle down, because the question here is somebody who's hungry, you're trying to snatch his food and trying to give to somebody who is not so hungry, just to make. So somebody who requires probably COVID-19, probably the RT-PCR for their survival kind of thing, and picking and then they're trying to use that for some patient with tooth extraction. So that's where the whole dilemma comes.
Correct. So we have to be positive and
It
probably
will
take
happen.
one day. Yeah.
It will happen. It will settle down. It will
Okay.
settle down.
Okay. So, sir, I have come to my end of this whole question and answer. Over to you now. You can guide me how to take it up. And
No,
if you,
it's fine. It's fine. So I'm happy about the discussion and all. All can have it as required and all those things. And we have to respect people and all. And every country has its own commitments and responsibilities and things, how it has to go on, how many kits are available, where they want to utilize, and funding and all. It's very easy. Sitting in probably in a comfort zone, we can ask, and our government has its own difficulties. But only we can tell is the two things, especially on a 3 point of view. If you have the facility for that getting tested and all those things, you get the testing done. Testing is negative, go ahead with surgery like routine, whatever you would have done. If it's testing says like a positive, wait for whatever the duration of the quarantine the country says. In case at the end of the day you don't have testing and all, treat everybody as clinically positive, and in case you got enough PPE to take care of all your personnel, you go ahead about the whole work. As simple as that.
right.
It will be fair enough. It will everything will be fine, Diptesh. It will be fine. Probably yes. Now we're like down. We'll have one more for saying thanks to everyone.
Correct. Thank you so much, sir. Thank you so much, first, not only for your time, but for your valuable discussions that we had. We had discussions at
We
length.
learn from each other, Diptesh. We learn each other.
Correct. Thank you so much for your time. And everyone, thank you for attending the session. I hope you all liked it. The recording is there on our website and YouTube right away, right now on our YouTube channel. And thank you again. Many thanks to Dr. Joshi for his time.
Thank you so much. Thank you, everyone.
Thank you.
Thanks a lot.
Thank you.
Bye-bye.
Bye-bye. Bye-bye.